Hi, good evening. Please can I welcome everyone to this extraordinary meeting of the Health and Environment Policy Committee, taking place from the Walton Suite in Winchester Guildhall. Time is 6:30. My name is Councillor Steve Cremoyson, chairperson of this meeting. This meeting is being live streamed and recorded to the Council's YouTube channel. Subtitles are available and advice on how to turn these on is set out on our website. And if I could just ask everyone just to check their phones are either switched off or on silent. In the unlikely event that it's necessary to evacuate the building, a fire alarm will sound. Please follow the instructions given to you by our team, or information handouts are available on your chair. And can I welcome first the members of the public and visiting councillors to the meeting. For those that have registered to speak, I will invite you forward when it is time for you to make your contribution. So let's turn to the agenda. Firstly, I need to ask for apologies and deputies. David, are you able to advise me on the apologies and deputies?
Thank you, Chair. Apologies received from Councillor Greenberg. We have Deputy Member Councillor Brophy here this evening. Also apologies from Councillor Warwick. We have Deputy Member Councillor Brooke here, and Councillor Tippett Cooper, and in his place, Councillor Williams. Thank you, Chair.
Thank you. And for those, in fact, actually, before I do the declarations of interest, as Councillor Tippett Cooper, who is our normal vice chair, is not able to be here, I'm going to invite nominations for a vice chair. Councillor Wise.
I'd like to nominate Councillor Morris.
Thank you. And seconder?
Happily second.
Thank you, Councillor Williams. Councillor Morris, if you'd like to come and join me up here in the usual space. Anyone would think we rehearsed that, wouldn't they? Well, while we're waiting for Councillor Morris to join us, just want to check if there are any declarations of interest. As far as I know, there aren't, but just in case I've overlooked that. Okay, I'm seeing shakes of the head, so I think we're good. Okay, moving on to chair announcements. For the benefit of anyone here who is not familiar with council meetings, so I'm doing this as someone who's only 3 years into being a councillor, and some of it was seemed a bit strange to me when I first went to a council meeting many years ago. So as with all council meetings, this is a meeting for our elected representatives, our councillors, to be briefed and to ask questions on whatever the topic at hand is. It is held in public to make it transparent as to what was said and what was discussed. The objective today is for members, the members, i.e. the councillors, to be briefed by the Hampshire Hospitals Foundation Trust, who are over here on my left, and to ask questions and to share their views on the consultation. These views will inform a formal response from Winchester City Council to the consultation, and that formal response will be put together and led by Councillor Becker, the Cabinet Member for Community Engagement, Councillor Becker being over here on my right. So what we hear tonight is not necessarily the whole outcome of what the City Council will say, but it will certainly inform that response. We have 4 members of the public who are registered to speak, and I will invite you forward in due course. Just so you know how this goes. I can't anticipate what you're going to say, what questions you might ask, what statements you might make, but those will be taken into account by Councillor Becker when she's putting together the response, and members or myself may raise those questions if you raise questions on your behalf. I have to say we've got a long list of questions already. I'm hopeful that your questions will, correlate with some of the ones we've got. So we're looking forward to hearing what you have to say. We'll do our best to cover your points. In terms of the practical aspects of the meeting, I anticipate at some point we might need a break during the meeting. So I'm going to try and find a time somewhere around about 8 or 8:15 depending on what feels like right with the flow, in which we can have a good point to have a short break. So just be assured there will be a break, and I'm not going to be waiting until 10 o'clock before we do that. And hopefully we will finish sometime between 9 and 9:30, which I believe is the expectations that have been set. Okay, so now we move into public participation, which is where our members of the public get to have their say. Let me just check I'm doing this in the right order. I think I'm doing this in the right order. So I'm going to invite forward. I'm going to invite forward the second on the list because I can see the first on the list has just arrived. And I want to give him a moment just to gather his breath, gather his bits and pieces together. So Philip Glassborough, could I invite you up to the mic over there, slightly on my left, and you can address the meeting. Thank you. You need to press the button on the right.
Okay, it's red. Is that good? Thank you.
That's it.
Thank you very much. First of all, can I just say thank you to the wonderful NHS team. We are blessed and very fortunate to have such very good NHS service and treatment in our area. But I would say that I do passionately feel that we need to have an A&E in Winchester. There are three. Of course. Gladly. Thank you. I wasn't sure if I was allowed. Thank you. I do passionately believe we need an emergency department in Winchester for two main reasons: access and resilience. I think at the moment we have two acute hospitals, Basingstoke and Winchester. We have two emergency departments, Basingstoke and Winchester. The three proposals on the table in the consultation, as you'll see, all three say that they will close the accident and emergency in Winchester. And I feel that it's very important for a city our size and importance with tourists and to have an accident emergency. So access, if all our emergencies have to be taken to Basingstoke, to the new hospital, whether in Basingstoke or Dummer, that will put an intolerable strain on the ambulance service. And then resilience, you may know that yesterday the hospital trust declared a critical incident because the attendance at the emergency departments was extremely high. And I feel that two emergency departments is better than one. Thank you very much.
Thank you, Philip. You've made those points extremely well. And could you just press the button to switch off the red light, and if you could take your seat. Thank you very much. So next up, I think if you're ready, Max Priestman, if you'd like to take the stand, as it were. I think you know the format.
Thanks very much for letting me speak, and thank you for giving me a chance to catch my breath again. So let me talk from my own personal standpoint, and also after I've talked to many others, locals. The main question should be, why do we need a new hospital? It sounds great to have a new shiny hospital, but one in a different place, not very close to Winchester. So the reason they stated was population, which is growing and gets older. In my view, not an argument to centralize care. Quality, but is that not down to lack of staffing due to lack of finances caused by austerity measures to allow tax cuts? Building, yes, they are crumbling, and we need to do something about it quite quickly. But in the end of the day, it comes all down to finances, I think, and that worries me. Let me ask those questions that I was thinking about, and I don't think I have time to answer them, but hopefully we can all think about them ourselves. Would a growing and aging population not require an increase in capacity in the places that exist rather than centralizing the care in a new place? How can we be sure that centralization doesn't lead to reduction of service, like less A&E? Where's the evidence that outcomes will improve this project, due to this project? Plans state that the Winchester site is too small to increase capacity. But where's the evidence for that? Is it not rather convenient to sell expensive land in Winchester? These plans accept that people from parts of Winchester district will choose to get to another hospital. Will that mean longer waiting times for them and others in neighboring catchment areas? What about their service? What about those patients who turn up in Winchester with an emergency and need to be moved to A&E in Basingstoke? Longer travel times would result in ambulances taking longer time to pick up and deliver patients to A&E. How will the ambulance services increase their capacity to accommodate for this? Will those who can't drive be even more disadvantaged? What about those people who like to visit their loved ones in hospital? How do they get there? Public transport is bad as it is, but these plans will make it impossible for many to get to the new hospital without their own car. Why are there no plans for public transport links included in those consultation documents? Why was Micheldever as a site excluded early on in the planning process, despite being the only central place with good links to railway line and motorway? Was it more expensive? What will the carbon footprint for building increased transport requirements running this hospital new site? Will this be carbon neutral?
Wrap up now.
Yeah, thank you. So in my opinion, this is a lot about money that the NHS doesn't have. And we try to accommodate this in one single place. I think there should be options to develop and modernize each site to match the growing demand. Thank you very much.
Thank you, Mr. Priestman. Thank you. Perhaps I should have just made it clear, we'll be asking the team over here on the left to try and pick up some of those questions when they do their presentation. I know that's what they do, so I forgot to state that. Right. Our next speaker is Danny Chambers. Danny, if you'd like to come up to the mic. The button has already been pressed, so you are ready to go.
Hello. Yeah, firstly, I want to say thank you to all the NHS staff for what you've done over the last few years, especially with COVID. I know it's been a really tough time for you. It doesn't surprise you in my role as a parliamentary candidate, because I speak to hundreds of people a month, and I can, although it's not directly within your remit, one of the problems of the community health care, like GP appointments, NHS dental appointments, mental health care, people struggling to get social care, that means people end up seeing Winchester Hospital and many of its services, including the A&E, as a safety net. And the discussion about many services from Winchester being moved possibly as far as Basingstoke has caused a lot of heightened anxiety from people who are really struggling to get the care in the community that they need. And discussing sort of funding, given that in your proposal in this consultation, you expect the new hospital to be up and running and built by 2032, it was really concerning to read in the Basingstoke Gazette just 6 days ago that there's no guaranteed Treasury funding for this project. And well, since we learned that last week, I guess the question is, have you received written confirmation from the Treasury confirming that this project is, and this hospital is funded in full, and so it can be delivered by 2032? And you'll forgive us for being a bit concerned about this, but this wouldn't be the first general election year where we've had a government promising us a new hospital, and we'd like some sort of apolitical, concrete guarantee of the funding over and above, Conservative MPs promising this in their leaflets. So thank you.
Thank you, Dan. Next up, we have Cons Muller. Is it Chons, I think? Thank you.
That's fine, thank you. Thank you, and good evening, and thanks for having me. I'm the current petition holder of over 16,000 residents of Winchester who strongly oppose the removal of the A&E and other acute services. As a lot of you will already know, Winchester has over 130,000 residents. It has 660,000 visitors every year, which has doubled in the last 5 years, and between 8 and 12,000 students. Now, the volume of this, from what I can gather, far exceeds Basingstoke. This doesn't include the other towns and villages immediately around Winchester. Having gone through the plans in quite some detail, it seems to me like one of the main issues is actually acquiring land. Given that the trust has been looking at various sites in Winchester, I would assume that Winchester is on the table for to site the new hospital. So my question is really, can the council and the NHS Trust work together to revisit some of these land options? Can they work together to negotiate and approach farmers and developers and landowners? Can they revisit the proposal when looking at Sir John Moores Barracks? And can they revisit the Barton's Farm development? And also, can they consider that Winchester College owns a lot of the land in the north of Winchester, which would be an ideal location for a new hospital? Thank you.
Thank you very much, Charles. Thank you. Right, we now move to visiting councillors. So if I could invite Councillor Wallace, if you'd like to come up to the mic.
Right, thank you.
I think your 3 minutes will be starting now. Apologies. That didn't make you jump. You've got 5 minutes.
I won't need that, but thank you, Chair. Firstly, thank you for coming to talk to us this evening. Clearly, a lot of work has gone into preparing this proposal and helping our residents to understand this important change to health services in our district. And I would urge everyone in our district to read the document, as it answers a lot of questions that I and I'm sure others will have about the project. Nevertheless, I still have a few questions. I have limited myself to 4, but my colleague has a few more covering some of the issues that I haven't raised. Firstly, it was disappointing to realise that this doesn't really appear to be a consultation for Winchester, as all 3 options that are presented lead to effectively the same outcome for our residents. Nevertheless, in order for our residents to better understand the new role of Winchester Hospital, please can you give an example of a local hospital that only manages planned surgery? For example, is the Lymington Hospital typical of what we can expect in Winchester in the future? A lot of assertions have been made in the proposals that the new hospital arrangements will lead to improved quality, reduced waiting times and a better service. These statements are easy to make now, but we all know of projects that have made grand commitments at the start but then get watered down over time. How can this council keep involved in the project over the coming years to track whether these commitments are being delivered? Part of the proposals talk about the impact of changes to people's nearest hospital, in particular switches to particularly switches to Southampton General Hospital. However, for our residents in the Meon Valley, the nearest emergency and specialist care centre is likely to be Queen Alexandra Hospital in Portsmouth. Has there been any analysis of the impact of increasing patient numbers on QA, especially as this hospital is already regularly reported as being under unprecedented pressure? Finally, my 4th question on net zero. The NHS has made the fantastic commitment to eliminate direct greenhouse gas emissions by 2040 and indirect emissions by 2045. In line with this commitment, the proposal states that the new hospital will help make the most of new technology and reduce carbon emissions to help get to net zero. Please, can you explain what work has been done to date on quantifying the emissions impact of the new hospital and how the net zero commitment will be achieved, especially given the increased travel that will be required to get to the new facility? Thank you.
Thank you, Councillor Wallace. Right, I think we'll now move to Councillor Horrell.
Good evening, and Chair, thank you for allowing me to speak to the committee this evening. I'm Councillor Caroline Horrell, and I'm sharing some of my questions this evening that I've gleaned from ward members in Wonston and Micheldever, which I represent. Chair, as you and I have discussed, I think it's unfortunate that you're asking the public and councillors to speak tonight before we've had the benefit of hearing the consultation presentation. But if I raise questions that you are able to answer, that would be really helpful. And I do apologise if you're covering questions that I'm going to ask already. Firstly, may I say I welcome the investment of 900 million by the Conservative government in our local NHS services. How best to do that is clearly the consultation process you're embarking on, and it is important residents take up that opportunity to comment. Thank you to the team for giving us that opportunity and for the presentation that you're about to give. Rather unhelpfully, there has been a lot of emotive language about A&E in Winchester. But can you please explain exactly what is a 24/7 doctor-led urgent treatment centre in language that all residents can understand versus the A&E department we know and love today? What will not happen in Winchester in the future? Some of my colleagues know my husband is rather accident prone. If I bring my husband along with a broken leg, will you treat him in Winchester? If I bring him in with a heart attack, will you treat him in Winchester? Can you tell us clinically what will not come to Winchester Hospital under the option for a new hospital at Junction 7, which is currently performed here today? Please, can you help us to understand tonight who decides which hospital you attend if it's not for predetermined surgery? Is it us as residents, clinicians who know the best place, or the ambulance crew if they're taking us to a particular destination? If Southampton is the nearer hospital, which is for many in our district and certainly in my ward, that would be the hospital that they may choose to be treated in because it's closer. Or will that not be a choice for them? Will ambulance crews decide where to go? And if so, what criteria will they use? What would stop this hugely important investment going forward to deliver first-class healthcare in our area? What is the alternative to your view, and what is the backup plan? And also importantly, what are all your staff saying about the plans? We know that they have been fundamental in the recent past, looking after us through our difficult times. They're the ones who make the system work now, and they're at the heart of the options development you are proposing. What are they saying, and how are they included? Thank you for the presentation, and I look forward to hearing more about it this evening. Thank you, Chair.
Thank you, Councillor Horrell. So finally, we have Councillor Lee. There you are.
Good evening, Chair, and thank you for allowing me to speak. And good evening, and good to see you giving us your time this evening. Apologies in advance. None of this was coordinated with my colleague and others. This is repetitive with a slightly different emphasis. I do apologise. So first of all, thank you for the information for this once-in-a-generation opportunity to improve Winchester and Basingstoke hospital facilities and services. Any proposal that delivers better sustainable health services for our community and value for money efficiencies for our NHS customers and taxpayers with improved net zero and wider environmental credentials is most welcome. In fact, is well overdue. But are the Basingstoke options the right ones? We've talked about this already. The travel is a big issue, certainly for my community, and the preferred Basingstoke option is of real concern to many Winchester residents, with the increase in transport and travel times to the distant acute services. Timely travel to access the key routes to Basingstoke from across Winchester can be unreliable and poor, especially via the M3 and A34 roads. Winchester residents will want to be assured that there are solutions to these transport and travel issues. The longer travel time for critically ill patients, especially during peak traffic, is likely to increase risks for patients. Will also disadvantage longer distance travellers to visit loved ones in a Basingstoke hospital. Double travel time for my Central Meon Valley residents in the southeast corner of the district. Additional travel costs will be on top of car parking charges. These distance residents without private transport will also have to rely on inadequate, unreliable and infrequent sustainable public transport, therefore are even more disadvantaged. I note that the Hampshire County Council's local transport plan, LTV4 as it's called, is most unlikely to address the necessary improved travel arrangements for any Basingstoke solution. So how does the Hampshire Together programme intend to resolve these travel concerns, including access to perhaps Portsmouth QA, the nearest acute hospital for many, which is already at capacity for Portsmouth Hospital Trust residents? And the second part of that question is, will budget limited residents have their additional travel costs and car parking charges addressed? Future-proofing the proposed hospital and health services in the consultation states that the proposals for new hospitals are part of a longer-term vision for hospital and health services in Hampshire and the Isle of Wight. Great. But have the future local development plans across the Trust catchment area, which will impact on the hospital location and services, feed in and meet all the options in terms of not overloading? Can you reassure this council and our residents that the right capacity and services for hospital and supporting services will be in place, A, when the new facilities are open and in the future? And allied to this is the need for reassurance that NHS illness prevention is included, plus primary care and social care in the right locations. This is of real concern. The Portsmouth QA hospital is, as I've said, under pressure, as are our local primary and social care services. The health facilities in Wickham and Bishop's Waltham are likely to see increased demand from the Fair and Wellborn, almost 15,000 residents, over a 15-year development period starting soon until local health services are in place. So can you reassure my local residents that future NHS illness prevention, primary plus social care will be improved to keep residents out of hospitals so the services are there for those that actually need them? Thank you.
Thank you, Councillor Lee. You covered quite a bit of ground there, so well done. Thank you. Right. Now we move to the main event. I'm trying to think of a cliche there. I will probably just keep to my script. So Hampshire Together and modernising our hospitals and health services. You've provided a consultation document which we've shared on our website over a week ago, and I think the consultation documents have been available for best part of 6 weeks since early December. So there's been plenty of time to assimilate all that information, including I think a 1,300-page document, which was riveting. So I will hand over to you to lead us through your presentation today. Over to you. Is it Caroline?
Yes.
Caroline Morrison. Thank you.
Thank you, Chair, and thank you very much for the opportunity to come and talk to you this evening. And also thank you for all of those questions. I hope as we go through this presentation that a number of those will be answered, but obviously there'll be opportunity to come back at the end and elaborate on further, and obviously your own questions. So we'll do some introductions. I think it's just worth saying that you've got a joint team here tonight. So you've got members from the Hampshire and Isle of Wight Integrated Care Board. So that's the organisation that, amongst other things, is responsible for looking at the planning and resourcing of healthcare delivery across Hampshire and Isle of Wight geography. And we also have the statutory responsibility for the public consultation as well. But very much working in a joint programme with our colleagues from Hampshire Hospitals, who are part of the new hospital programme. So if it's okay with you, we'll do a quick run through who we are and then we'll get into the slides. So I'm Caroline Morrison and I'm the Chief Strategy and Transformation Officer for the Integrated Care Board.
Good evening, everyone. I'm Dr. Lara Alloway. I'm the Chief Medical Officer for NHS Hampshire and the Isle of Wight, the Integrated Care Board.
Good evening, I'm Alex Whitfield. I'm the Chief Executive at Hampshire Hospitals. So we run the hospitals in Basingstoke, Winchester and Andover.
Good evening all, Nick Ward. I'm a paediatrician at the hospitals and I'm Interim Chief Medical Officer.
Good evening, I'm Charlotte Hutchings. I'm a GP and Clinical Director in North and Mid Hampshire for NHS Hampshire or the Integrated Care Board.
Thank you, and hopefully that was clear for everyone. So I also have the duty of slide management tonight. Yep. Done that. So moving on, and also apologise, I know some people have seen these more than once now, so they'll begin to become quite familiar. But really, we believe this is an incredibly exciting opportunity for a once-in-a-generation investment in hospital and health services for the population of Hampshire. And within that, there's a really important factor that this is about two excellent hospitals. Royal Hampshire County is absolutely front and centre of all the work that we're doing. And as we go into describing a little bit more around the models of care and the services, hopefully that will start to become clear. We absolutely understand that there are concerns, anxieties about sort of what that new model of care looks like, but we will work that through. And it's really important also just to reiterate that the process we're in at the moment of consultation is the point at which we gather that widespread feedback around views, opinions, thoughts. So that's the context in which we're here tonight, is to talk about the proposals and gather that feedback, and I'll come on to the process around that a bit further down the line. But just to summarise, we're part of the New Hospitals programme. We've been sort of allocated the £700 to £900 million to build two excellent hospitals for Hampshire. It is a once-in-a-generation opportunity to think about those facilities for services, but also within that to think about how we develop what the models of care look like for our future generations, because we will know, and members of the public and Council College have reflected, that there are changing demographics, there are changing needs, and combined with looking at buildings, we can look at how we want to deliver those services to really make sure that we're delivering the best outcomes for our population. And really importantly as well, think about how we are attracting and retaining our staff. Workforce is critical for how we deliver health and care services. And without having the best staff and being able to deliver those services and keeping those staff, that becomes a challenge, and giving our staff the opportunity to work in the facilities that they would aim to and aspire to work within. The proposals that we're going to talk to you tonight about really put patients and families at their heart. But as I said, we are here to talk about the proposals, but also very much to listen. So on that front, I will hand over to Alex to talk a little bit about the case for change.
Thank you, Caroline. Thank you. So it's interesting. One of the questions has already come up. Why can't we just develop and modernise our existing sites and then leave the services as they are, but just in better, higher quality buildings? And we think there's 4 reasons why that isn't the best use of the money, and why actually this is an opportunity to change things and make them better. The first is the changes to our population. We've already had that referenced. We've got more people living in our catchment area, houses going up, people moving in, and we've got people who are older than when our hospitals were built. So Winchester, Royal Hampshire County Hospital in the 1800s, the population's changed significantly since then, and Basingstoke in 1974 when that opened. The second reason is that we have duplicate services. So we have a range of services. We have lots of things we provide in lots of locations, things like outpatient appointments, things like scans, x-rays, blood tests, physiotherapy. We provide them in Winchester, but also in Basingstoke, in Andover. We do some things in Eastleigh and in Newbury. And we want to do all of those things in as many places as we can, for exactly the reasons people have raised, that the things you come to hospital for a lot, you don't want to have to go too far. And there's no reason why we have to ask people to travel far for an outpatient appointment with a doctor. In fact, during COVID, we started doing quite a lot of them over the phone and video, and we've continued that where it is appropriate for the patients and the clinical care. So those things stay the same. We have some services that we only run once. So we run our stroke service out of the Royal Hampshire County Hospital. And if you have a stroke in Basingstoke, you get taken to Winchester. And that's because there is loads of evidence that if you can be seen by a stroke expert very, very quickly, then that can transform your outcome. And stroke care across the country has been transformed by centralising the care into a smaller number of hospitals, which can provide 24/7 access to all the right equipment and all the right people. The same is true of cardiac heart services, but we run that out of Basingstoke. So we have a thing that's called the cath lab, which is where if you have a heart attack at 2 in the morning, the ambulance will take you to Basingstoke, even if you live in Winchester, and they will, the doctors, the radiographers, the team, the nurses, they will be there ready to meet you, and they will put a stent in your heart and save your life. It is amazing. Now, to do that 24/7 and have that team ready and waiting and all that kit in more than one place just isn't feasible. So we do all of that in Basingstoke today. What we want to do, and Lara and Nick will talk a bit more about the clinical arguments for this, is those things that we only do once would make more sense to do in the same place, because the ambulance service is then just bringing people who are in acute need, that need an intervention right now, to one location. We also have some things that we run twice still today that we could run better if we ran them once. And that's things like our obstetric maternity service. And again, Lara and Nick will pick up a bit more around this. The third reason why we want to change things rather than just rebuild existing is that the hospital buildings we have are at the end of their usable lives from two aspects. The first is the maintenance. So we'll talk about Winchester because we're in Winchester. Our electric supply and system around Winchester is quite old, and we have to spend an awful lot of money on transformers and electrical cabinets to try and upgrade that to modern standards. Many of you may know that we have been preventing people using the gardens because the roof tiles fall off and it's not safe. The lifts break from time to time. So there's all these maintenance issues. But the second way that the hospitals aren't fit for purpose is that if you were building a hospital today, you wouldn't build it to look like the Royal Hampshire County. Beautiful as it is, and it is beautiful, the frontage. Hospitals built today have single rooms, so patients aren't in a bay with 6 people, some of them keeping them awake at night, lights going off, alarms going off. They're in their own room, often with their own bathroom. That what we find is that patients sleep better, they don't catch infections, they eat better, that they get better more quickly. And we want to build those kind of buildings, have those kind of facilities available to the people of Winchester. So we can't do that within the Royal Hampshire footprint. It's congested site. You couldn't suddenly turn those 6-bed bays all into single rooms and keep everything as it is. The fourth reason rather, it does relate to the money, and it's interesting. We heard comments about the money, and is it all about the money? We do spend taxpayers' money, and we have a duty to spend it well and not spend it in ways that are unnecessary or don't really benefit patients. And so what we want to do is make sure that every penny we spend of taxpayers' money is really helping and supporting to make people better and provide modern healthcare services to the people of Hampshire. So those are the 4 reasons why we believe that we're not about just replacing what we've got, but we're actually trying to plan for healthcare in 10 years, 20 years, 30 years, and we need to make changes. And I know it's difficult, but we've got to do the right thing for the future, not just for today. So the next bit is about how we've come up with the options, and we've already heard concerns that, you know, the options, the model for Winchester is the same, and why is that? So let's just explain briefly how we've come up with the 3 options that I know many of you will have seen already. We started this back in 2019-20. So in the autumn of 2019, we heard we were on the new hospital programme and that Hampshire was getting significant capital. And so through the summer of 2020, we ran a whole series of Zoom events. And I know some people in this room were on some of those. And we said, what matters to you? We then looked at the wider context and said, what's happening with national policy, with international best practice? If we were designing a healthcare system from scratch, what would it look like? And the kind of things people said are, we don't really want to be in hospital unless we absolutely have to. We'd rather be at home. We'd rather, if it's safe and high quality, receive our treatment at home or close to home. So how do we use digital technology to enable that? We heard a lot about please join up services across health and care so that we're not having to tell our story multiple times, so that our records transfer. And we heard a lot about the best practice in the world is that if you are having those very rare but really important incidents like a heart attack, like a stroke, you need to get to the specialist with all the kit and all the expertise quickly, and you need that treatment really quickly. And so we use those principles to design a variety of options. And we started off with lots and lots of options. And they got refined by our doctors, our nurses, our physiotherapists, our pharmacists. It was the clinicians who designed them, but with involvement from patients and other stakeholders. And we've talked about people like Southampton Hospital and Portsmouth Hospitals. They've been involved, the ambulance service, our GPs, you know, other partners as well. And then we took our options to a thing called the Clinical Senate. And we went 3 times and explained this is what we think we should do. And they gave recommendations and advice. They have access to all of the best practice around the world, and they refined them to come up with the 3 options that we're going to talk to you about. And if we just go on to the next slide, we've sort of added in a couple for, I was talking to Stephen earlier and saying we're not allowed to change the slides, but we added in a couple about to answer the question about why isn't there an option here that says there's an A&E in Winchester? You know, why haven't you given us that option to comment on? And these were the principles we evaluated the options against, and they were about they have to improve patient outcomes. We have to say that this will improve safety, improve quality of care, improve experience for patients, and accessibility. And I know that might sound a bit contrary, you know, how does this improve accessibility? But it's about getting access to expertise really quickly. We had to improve clinical sustainability. So it's all very well to have a model, but if you're never going to find the doctors and nurses to staff it, then it's not real. So how do you make sure it's something that can actually be staffed and that can continue into the future? How is the infrastructure fit for purpose, and how does it improve financial sustainability? So the next slide has a bit of a graphic of the funnel. We had all these models and we went through these hurdle criteria. And the reason the A&E in Winchester didn't get through all the way through the funnel, because it very much was in some of the options early on, and in fact until quite late in the day, was that the expertise said you can provide better care with the model we're proposing. And there's 3 groups of staff, 3 groups of patients who use an A&E. And I'm sure Nick and Lara can talk more about this from a clinical perspective. But the first group are the ones who are taken there in an ambulance with a blue light for a heart attack, a stroke, a fractured hip, something that needs a very immediate response. That group of patients are better looked after in a big hospital with lots of services, lots of kit, lots of expertise, 24/7. And we can provide better care for those patients by doing it once across Basingstoke and Winchester. The second group are the patients who take themselves, or their parents take them, or they take their parents, or a neighbour brings them in. And those people are better cared for in what's called an urgent treatment centre. And I think we'll come on to a bit more description about what that means. But that's probably the kind of thing most of you, if you've been to A&E and you didn't call 999, but you went because you had an injury on the football pitch, or those are the things people take themselves for. Across the country, urgent treatment centre waiting times are significantly shorter than emergency department waiting times. And that's because the doctors and nurses who work there aren't having to drop the care of that patient because somebody's just arrived in an ambulance that everyone has to worry about. They're just able to care for the people who are coming in. And the third group is probably even less well understood, which is when you go to your GP and the GP says, I need to send you up to the hospital. And today, quite often, that means I need to send you up to the A&E. Now, what we're putting in place are a whole load of models where actually the GP, like Charlotte, can say, I think you need to see a cardiologist, a heart doctor. So I'm going to book you in for a same-day appointment with a cardiologist. And that is a much better service than sitting in an A&E with all of the blue light ambulance survivors and everybody else. You get straight to the expert who you need to see. So we think the model we're proposing is better for all three of those groups, for Winchester residents, as well as for Basingstoke, Andover and Alton and everywhere else, that actually you'll receive better care with better outcomes, shorter waiting times. And I know that's really hard to put on the side of a bus or a headline in a newspaper, but that's why there isn't an option here that says an A&E in Winchester. I shall now hand over to Lara, who's going to talk through the options a bit more.
Thank you, Alex. So I think trying to pick up some of the questions, as Alex has said, it was the clinicians in each service in the hospital who considered the issues that they were facing and what they felt the best model moving forward was. And we then brought that together. We then brought GPs, community nurses, paramedics into that conversation. So to assure you, these models have been designed and continue to be iterated by the clinicians. So the other thing, I'm going to talk through the model of care, which is about the hospitals. But I think as we've tried to make clear throughout this, we absolutely do not see this in isolation. It's the community and the primary care services, local care outside of the hospital, which is key and actually provides the majority of the care that the population seeks. So, you know, out of hospital, and we can pick that up a bit more, Charlotte can a bit later, but this is going to focus on the hospital, but we absolutely, just picking up the point made earlier, out of hospital care is as important, if not more important. So, our clinical model of care has two excellent hospitals. So we've got one hospital with a dedicated planned surgery centre. This has the doctor-led 24/7 urgent treatment centre and same-day emergency care. So picking up the question, if your husband breaks his leg and you are taking him in the car, you just about get him in the car, he would go to the urgent treatment centre. If your poor husband has a chest infection which isn't responding to tablet antibiotics at home, you've spoken to the GP, you're concerned, you would take him to the urgent treatment centre. So actually a lot of things can, and we as Alex said, think 2/3 of the conditions that people go currently to the emergency department will be able to be managed here. And we've done lots of work to go through looking at what everyone has come to Winchester ED with and to see where they would need to go in the future. But the heart attack would not be treated in the urgent treatment centre, as Alex said, and actually it wouldn't be treated in Winchester ED at the moment. So in this hospital, we've got the 24/7 urgent treatment centre, and it is important it's doctor-led because that means we can do a lot more than perhaps some of you may have been to the minor injury unit at Andover. That is very, very different. We've also in this hospital going to have a dedicated planned surgery centre, which will do about 80% of the planned operations that are done across Basingstoke and Winchester currently. So this will be ring fenced, that it will not be impacted by emergency urgent care. And at the moment, unfortunately, because the hospitals across Hampshire are so busy with emergency care, as people have mentioned, at the moment, the planned operations are unfortunately having to be postponed in many cases. So we recognised in COVID some of the advantages around infection control, and we recognise in winter that separating planned surgery is really important. And this is happening all over the country. People are recognising the benefit of this, to have focused areas where people won't be cancelled, be able to run the expensive resources of operating theatres and all the staff involved, anaesthetists, surgeons, theatre nurses, ODPs, all of the staff for longer every day. And what we'd aim to do is 7 days a week, which currently we can't do because we're providing various different bits of surgery in various places. Then we will have the ability to be admitted into a bed in this hospital. So if, and picking up the question of who decides, if actually your GP has decided, or triaged, or 111, or our clinical communication centre decides that you're unlikely to need the services of the acute specialist hospital, you could go be admitted to this hospital. And in the same way, if you go to the acute specialist hospital with a heart attack, and actually you need a bit of ongoing care after the immediate treatment, which is actually these days quite unusual, but you could be stepped down nearer to home if that's what you required. We'll also have a midwife-led birthing unit here. And most importantly, in all of the hospitals, in all of the options, we'll have those frequently accessed services. So thousands of outpatient appointments that are provided every week, diagnostics, X-rays, CT scans, MRI scans, and therapies will be provided as they are now in this hospital and the acute specialist hospital. So the acute specialist hospital will be where the emergency department and trauma unit is, and that will also have a dedicated children's emergency department. And that will largely be people who go in a blue light ambulance, because actually the paramedics think that's the level of care that they need. And this will also have an urgent treatment centre alongside it, because we so believe that separating off that care from the true emergencies is much better for people and their experience, as well as the speed they access care. In the specialist acute hospital, we will have the emergency inpatient care. So where you go with a heart attack, a stroke, a broken hip that requires an operation, a bleed, severe bleed from your gut, all of those things that we recognise, picking up Alex's point, where actually we need our consultants to be there for as many hours a day, leading that care and bringing two services together, means that we can provide that senior decision making for much longer across a 24-hour period. This is where we'll have the intensive care unit. So the emergency surgery would be done there, because sometimes that does require the support of an intensive care unit, but also the very complex planned surgery. So that's some complex colorectal or gut surgery for cancer that we do, but also we have a very specialist peritoneal malignancy surgery service that would be provided there. It is where we'd have the obstetric-led maternity care, and that's bringing the obstetricians together to provide longer hours of cover, as well as an alongside midwifery birthing units. That's providing much more choice. It will mean we have enough births and the staffing to support what we call a level 2 neonatal unit, and that is caring for babies from 28 weeks gestation. So those that need special intensive care, that currently there are about 100 or so babies who we couldn't currently care for in Winchester or Basingstoke, who would need with their families to travel to another centre like Southampton or Frimley. It is where we'll have inpatient children's services, as well as a cancer treatment centre. So that's radiotherapy and the more specialist chemotherapy that requires a longer period of time. And alongside that, in a cancer treatment centre, we'll provide that supportive care, all in one place. And as I mentioned, the frequently accessed services will be there. So coming back to who decides, actually, if you're very sick, the paramedics decide. Quite often your GP or 111 will guide you, but where you're making your own decision, the most likely thing is that your needs could be met at the urgent treatment centre. And important to say that people still have choice. So, you know, we can't provide everything in both hospitals, but choice does come into it. So moving on to the next slide, just to talk about the potential locations for the new hospital. And there's been a few questions around that. We've spent, as several of you have mentioned, a long time looking at all the options for a location for this new hospital. And we've had independent consultants looking at this, and we had 30 criteria that all of the sites were judged against. So it was everything from accessibility, the size of the site, availability, and thinking about accessibility of the whole catchment population, as well as affordability. But 30 criteria. We've got more information on our website about this. But what we have come down to is 2 potential locations. So one is the current Basingstoke Hospital site, the north site, and then the other is the junction 7 of the M3 site. And we've just shown where the Royal Hampshire County Hospital is on that map. So on the next slide, we then combine the clinical model and the locations into our options. Now, I think probably most of you have seen this, so I'm going to whiz through it. We've got 3 options. So in option 1, the specialist acute hospital is on the Basingstoke Hospital site. In option 2 and 3, the specialist acute hospital is on the junction 7 of the M3 site. In all of the options, we are proposing that services at Winchester Hospital, the planned surgery centre, with significant investment in the buildings to bring them up to the standards that we should have in modern day healthcare, and this dedicated planned surgery centre and all the other services that I've mentioned, they would be the same in all of the 3 options. As with the services that I've talked through in the new specialist acute hospital. In option 2, we do have a few services at the current Basingstoke Hospital site. So that's some outpatients and diagnostics, x-rays and things like that, and a very small amount of day case surgery. And then in option 3, it's the same as option 2 with some step down rehabilitation and reablement beds if people need ongoing hospital care but actually not intensive medical input. There are some beds in that option 3. So those are the options as we're proposing them, and I'll hand over now to Nick.
Thanks very much. So we've already spent quite a lot of time discussing the advantages of the 3 options and why that's how, as a group of clinicians, we have elected to present in this way, to use what is a really exciting prospect about how do we spend this money that we've got available to build a new hospital. I genuinely feel as a clinician that this is the best way that we can provide the best care to our patients. And whilst I completely understand the anxiety and the emotions in what's being seen as a reduction in services, I genuinely believe that actually that isn't what we are suggesting at all with our proposals, because we are continuing to provide a lot of care on the current sites as they are, and particularly on the Winchester Hospital, with significant redevelopment of the Winchester Hospital. And we're continuing to provide the vast majority of the urgent day-to-day care at that site as well. But there really are, and everybody who works in the hospital and in the specialities that provide acute care, there really are significant advantages to bringing those specialities together to allow us to provide that best quality care. What we whilst the moving the site of where that happens is going to have an impact on travel time for some members of the population that we serve across Hampshire, absolutely accept that. What we feel is the most important thing about the quality of care and the outcome of your illness when you get acutely unwell is the services that are available to you when you arrive at the destination, when the ambulance doors open and your specialist heart team or your specialist stroke team, or indeed your specialist intensive care doctors and assisting the emergency department consultants are there and have the time to focus on you whilst you are in that critically unwell position. And likewise, for those conditions that don't need that immediate super specialist help, there are clinicians working in urgent treatment centres who are able to provide the majority of that same day care. The separation of emergency and planned care we've talked about, and again, I think as a clinician and for all of our teams who are actively trying to juggle the emergency operations that come in, as an example, against the elective operations and the people that have been waiting an extremely long time to have their elective operations, those planned procedures. Every day there's a juggle to try and be able to do to fit both of those in. It was mentioned by one of the speakers, and forgive me, I can't remember who, about the difficulties that we've been having in our emergency departments and across the hospital over the last few days, and absolutely accepted, very significant pressures on our services, both in the emergency department, in being able to move the flow of patients through the hospital, and being able to discharge some of the patients who perhaps no longer need the medical and nursing support that's in a hospital, but do need some ongoing care and the time that it can take to set that up and provide that care. And all of that impacts on our ability to provide planned care and to be able to get through and recover, as everyone understands, the long waiting list that built up significantly during the pandemic, which the teams are working extremely hard on at the moment, but to be able to do that in sustainable fashion, the separation is absolutely where the direction of travel is. And as an example of that, and I suppose to demonstrate the importance with which we place Winchester in our thinking right now in the Winchester Hospital is the development of an elective orthopaedic centre, which is due to start building this year, and is a multi-million investment into Winchester Hospital that will increase and allow us to do more elective procedures for orthopaedic patients. And that's a joint approach with the team in Southampton as well, demonstrating that we're working closely across the health community to provide the best care that we can. So if we move on to the next slide, thank you. So this slide, it's got quite some more writing, so I will explain what we're talking about here. So there clearly are advantages and disadvantages to the options, and I hope to try and help you understand why it is, on the whole, we feel that option 2 is the preferred option. So in option 1, which is to have the acute hospital on the current Basingstoke Hospital site, that does mean that the NHS doesn't need to purchase any land that it hasn't got, and it does have established public transport links already. And we have heard absolutely the number of comments about the public transport and the requirement to ensure that we can support the provision of travel to our hospital sites. But by building the new hospital in the north of Basingstoke, that does have a bigger impact on more of our population in terms of travel times, which we accept that. It increases the chance of some of the population that currently use Hampshire hospital services of going to other hospitals, and we don't want to do that. We want to continue providing care for the vast majority of our population as best we can. It's also a lot more complicated to build a new hospital whilst continuing to provide the care that is provided on the Basingstoke Hospital at the moment, making it more expensive, and it takes longer to do that. So whilst that is an option, we do feel that there are significant disadvantages to that. In option 2, which is a new site that allows the build to go ahead without disrupting current services and allowing our amazing staff to carry on doing what they're doing in the interim period. Healthcare is changing, and we've already described significant changes in what we're providing and what needing to provide for our population, and that will only continue. And I suspect the requirements will change more rapidly than they have until now. And we're very aware that it's very likely that in the future we will need to expand any new hospital further to allow for the development of new services. And whilst we're already suggesting a number of new services that will be able to be provided using this investment, such as the Children's Emergency Department, it's very likely that further new services will be needed, and there will need to be space to allow that to happen. And space is a significant impact, particularly at the moment on our sites, and I have to say particularly in the Winchester Hospital, which has been expanded significantly already within its current footprint. That's also had an impact on how we can best look after our amazing staff as well. And unfortunately, there are some situations in both our main hospital sites at the moment where we've had to take away or diminish the amount of space our staff have for education, for relaxation, to allow us to provide patient care in some of those areas. And as part of the new hospital programme and building a new hospital, how we look after our staff and where our staff can take time is a significant part of that. And it's quite exciting when you look at the suggestions that are coming out of the new hospital programme at the moment about staff facilities. However, in option 2, we would need to find and purchase the land, as Alex started to talk about, and there's already been significant work that's been done into the possibility of that. We have to provide the options that are feasible. We can't provide options that haven't been fully thought through and possible for us to provide that, and that's why we've ended up with the options as we are at the moment. Clearly, as has been said, we don't hide at all behind the fact that there will need to be significant changes to the public transport infrastructure to allow for travel to the new hospital as well. The difference between option 2 and option 3 relating to the provision of some inpatient services on the Basingstoke site, we feel would require more money to redevelop further more of the Basingstoke site than would be needed in option 2, and also has an impact on our valuable nursing workforce to spread them out over even more sites than we are planning to already. So we feel that whilst again that's an option, it's not as preferable as providing the inpatient care on our 2 main hospitals that we're describing today. This is a reminder that the vast majority of patients that use our services will be able to continue using the services that they do in the current site that they do at the moment. So we have well over 550,000 outpatient appointments that we provide across all our sites and our outreach centres from Hampshire hospitals, and that will continue. And in fact, by going with option 2 or 3 and building the new hospital in Junction 7, the variety of where those outpatient services will be delivered increases further. And we'll continue and are already continuing to work hard with our population that we serve to think about how best we can minimise travel even now for those frequently accessed services and outpatients by using the information technology and video consultations. The day case treatment, the X-rays, the diagnostics, the scans, all of that will continue to be provided and developed in the interim period up until the new hospital. And again, the majority of people who use our services are not there for inpatient stays or for very acute emergencies. They're there for the planned care and the outpatient services, which will continue to be provided. So I think I'll stop there and move over to Alex, talk about travel times.
Travel times, thank you. So we've got 3 slides on travel times. Now, these are generic for the whole of the Hampshire Hospitals footprint. And so what these talk about is the maximum and average travel time changes for everybody from Newbury to Oldham to Andover, which isn't terribly helpful if you're sat in Winchester. So while the slide is up there, I'm going to just talk about Winchester specifically. The first of my 3 slides is about urgent care, travelling under a blue light ambulance, or when you need to get to hospital quickly by car. And what we know is, as we have discussed, the most important thing is that the hospital you are going to with the blue light ambulance is ready to receive you and has the care that you need when you get there. We have looked at the changes to those travel times. So if you live in Winchester today, if you have a stroke, you go to Winchester Hospital, very quick. Under our option 1, you would go north to Basingstoke current hospital site, which is quite a bit further. And under option 2 and 3, you would go to Junction 7 site, which is not quite as far as the Basingstoke North, but still further than you go today. What we know is that all of those travel times are safe and will provide you with the high quality care that you need and will not impact on your outcomes. If you have a heart attack or a trauma event in Winchester today, as I say, you would go to Basingstoke North, the current Basingstoke site. So under option 1, that doesn't change, same travel time. But under options 2 and 3, you have a slightly shorter travel time because Junction 7 is closer to Winchester. The other thing to bear in mind is that when we've done all this analysis, we have assumed that all the people that come to Hampshire Hospitals today still go to Hampshire Hospitals. But the reality is that if you live in the south of Eastleigh and you might come to Winchester today for your stroke, it is entirely possible that you would go to Southampton if the stroke service moved north. And as Lara said, that would be decided by the paramedics at the time. If you weren't capable of making the decision, if you had a particularly strong view about where you wanted to go and you were able to articulate that, or your family were, then the paramedics do take that into account. They don't just say, we're taking you here, but they will advise about, actually, we think the very best place for you is Southampton, or is the new hospital, or is Winchester. So the bottom line is, in a blue light situation, the travel times are all still safe and provide high quality care. The next slide is about for planned care. Now, for Winchester, this is much more straightforward because we are going to be doing even more planned care in Winchester. So this is where you've booked your hip replacement or you've booked your cataract operation and you're making your arrangements and you're travelling by car and you would be able to get to Winchester. You'd go to Winchester today, you'd still go to Winchester in the future. So there's no change for a Winchester resident in terms of that planned care travel time by car. The other thing to say about car travel and to the new hospital is the parking situation. I think it was Councillor Lee talked about the costs and the parking. We know that the current Winchester Hospital site is not great for parking for either our staff or our patients or their visitors. And so one of the key things about the new hospital for people coming by car will be the need to ensure that there is enough parking and it's easy for staff, for visitors and for patients to get to. The third slide is about public transport, and we've already talked about this and the fact that there currently is not public transport to the Junction 7 site. In fact, when we looked at how our patients and our staff access our hospitals today, most of them drive. And that is because across the whole of the county of Hampshire, the public transport network isn't great from all of the small towns and villages, which is actually where most people live. I know we think about, the metropolises of Winchester and Basingstoke and Andover and places, but more people live in small towns and villages spread out. And so people do use cars, either their own or driven by a neighbour or a friend or our brilliant volunteer drivers who take people to hospital. That doesn't mean that our plans should assume that everybody can drive, because we absolutely know that in those metropolises, car ownership levels are much lower because people don't necessarily need a car if they live in the middle of Winchester or the middle of Basingstoke today. And so while I would love to be sat here and saying to you, we're consulting with the public and we've got a fully worked out public transport offering, the reality is that the conversations we've been having with Hampshire County Council and others and bus companies can only go so far while we're still deciding on the site. Because if we decide to go to Junction 7, then they're really keen to have conversations about how we get public transport to Junction 7. But if we decide that we're staying at the current Basingstoke Hospital site, then those conversations would have been pointless and a waste of their time. And given that the timescales we're talking about are a 2032 opening, currently there are very few people prepared to talk to us about bus timetables in 2032. What we do have is commitment that we know we need transport solutions. And we look at new hospitals around the country, and most of those are provided by the local authority, public sector, public transport network, but there are also options, and we've talked about things like shuttle buses that might run to the hospital that we might need to put on in order to support family, staff and patients to get to the new building. And we need to work that all through once we know which site we're going to. So that's where we are. I think we're on to the last little chunk, which is Caroline on consultation.
Yes, thanks, Alex. On to the home straight on consultation. So this is our really important part of the programme of work now. We're in a 14-week period of consultation. So we launched on the 11th of December, just in time for the festive season, and we run right through until midnight on the 17th of March. And this is where we hear and gather widespread views, opinions, thoughts on the proposals that we're talking to you about this evening. And particularly on the two areas that we are focusing on. So one around the model of care. So all of the kind of clinical evidence and the discussions that we've described in terms of what those models of care look like going forward in those proposals, and also on the site options. And we've touched on that as well. Along with other opportunities for feedback and thoughts. So those then get taken into account as we move forward through 2024, and those alongside further analysis and information around sort of clinical evidence into a decision-making process. And I'll go through the timelines a little bit further on that. So just to reassure, these proposals we believe are really about delivering the best outcomes for residents in Hampshire, including the residents in Winchester. And we are really keen to hear people's thoughts, opinions and views on that. So here are some of the ways that people can get involved. We've got our website, our consultation document, which hopefully it sounds like has been read and people have access to that. Open invitation to be invited to groups and meetings, and our team who are running the consultation are busy liaising with people who come forward with that as an option and as a suggestion. We're running a whole number of events, so we've got a number of face-to-face events. We've run a couple of Winchester already. We've got some coming up further on in the process, and then also obviously across the footprint, and virtual events as well. And as well as for members of the public, also for staff, because it's really important that we hear views from our staff as well. There's a consultation questionnaire, which I will also come on to in a second, and we are really keen for people to contact us. So all of those details are in the consultation document on the website. So it's really an open and very sort of welcome invitation for people to get in touch. So some of the areas that we are seeking views on are around the case for change that we've talked to earlier on, the models of care, locations, advantages and disadvantages, and any other options, solutions, ideas that people want to feed in. I think it's really interesting. We've been through a number of events already, and each time we hear something new and different. So, you know, there's huge value in having these conversations and discussions with people. And I think the other thing to say is the more specific and the more sort of information that people can feed into those questions, the better for us, because it gives us something that we can work to and then look at how we respond in a meaningful way as we go forward through the next decision-making element of the process. So here's just a quick timeline in terms of what happens next. As I said, we close at midnight on the 17th of March. All of those responses then come together, and we've got a third-party organisation who analyses all of those themes and gives us a really rich report back that we can then use alongside some of the evidence from the business case we already have around clinical, workforce, estate, financial information, and all of that comes together into what we call a decision-making business case later on in 2024, and a decision then around which option we implement. Moving then into implementation around the construction of the new hospital, and with the real ambition that we expect to open the doors by 2032 is absolutely our aim for those two new facilities. And then really just a bit of we use every opportunity for a bit of a call to action. So here are all those contact details. And I think one of the things we are really grateful for as well are the kind of activities of people in this room in terms of galvanising interest and sharing and disseminating this information, because we can obviously put sort of press releases out and through our channels, but actually that word of mouth and the conversations and discussions that people are having are what really draw people into those into contributing and sending their opinions back. So I think that comes to the end of that. Thank you.
Excuse me. Thank you very much for that extended briefing, and for also introducing just a little bit of colour on the selection of sites. And I love how when you're looking at a high level pitch, something like construction of new hospital ends up being a bullet point. And I'm sure that hides a multitude of sins and work and all sorts of stuff. So, but thank you very much for that. That's been really useful. I'm just going to have a quick word with my vice chair. Right, we're now going to move into questions and discussion, and the format here is where members here on. So sorry, I'm having an appeal.
Sorry, Chair. I was going to ask if we arrange for the comfort break now as an appropriate time, if possible.
Okay. If I'm assuming that reflects a need. So I think rather than moving, I was hoping we could get through at least one chunk of questions. But as you've made your appeal and provided us probably some information, I think we should have a comfort break for it's until 8 o'clock. If we can make it quick, because I would like us to get through and give ourselves a chance of finishing by 9:30. I suspect what the track we're on. So 8 o'clock, please. Okay, I hope we're suitably refreshed. Thanks very much again for your presentation. Awful lot to take on board there. I'm now going to open it up to members for questions. Right, first up was Councillor Brooke. So members, if you would like to, if you want to just indicate that you have a question, Councillor Morris here will start running a list.
Thank you, Chair. Thank you for the presentation. It was really helpful too, and also to hear some of the audience's questions, public questions from the start. I wanted to ask, are the catchment areas moving or are they just merging? I'm thinking the likes of Bishop's Waltham, who currently would go to Winchester Hospital because it's closer. If this moves further north, QA might be closer, Southampton might be closer, and what the other hospital trusts' input and feedback has been on this, because it might add additional pressure.
It's a really good question. So the first thing is that catchment areas aren't fixed. So people, for example, in Bishop's Waltham might choose Winchester for some services, but might go to QA for something else, and there's a lot of patient choice that is involved. So what we've done in the modelling is try and work out, we talk about patient flow, which patients may or may not choose to go somewhere different if a service moves. And what we know is that by keeping all of the outpatient appointments, the diagnostic tests at Winchester, actually that to some extent locks in a lot of the care that people will say, well, I'm going there for my outpatients and so on. So actually I'm seeing the surgeon happens to be operating at Basingstoke, but that's fine because I know him and I want to go with that route. So we've tried to model what decisions we think people might make. It's very difficult. So if you look at something like the border with Southampton in the south of Winchester, trying to work out whether for those really urgent care episodes, people will say, I like the thought of a new hospital with lots of parking and a single room, versus it might be 5 minutes quicker to go to Southampton, versus it's the middle of the day and the avenue's gridlocked. And I think so it's very difficult. So what we're, particularly in our conversations with Southampton and Portsmouth, we're trying to work out what are the ranges of activity that might move. And therefore, how do we make sure on the day we open the new hospital that we don't end up with one hospital completely full and the other one with loads of space. But I think the reality is we're never going to get the exact number. So we need to be robust to a range of options about how people may choose to access care. Yeah, it's not easy, but there isn't like a fixed catchment where you say, if you live here, you're now, it's not like school catchments, you're now going to that hospital. People choose, and they choose for all sorts of reasons. Yeah. Don't know if anyone, do you want?
Yeah, just to come in, how have we been working with them? So we have, as clinical teams, as well as executive and management teams, been working with the neighbouring trusts and actually thinking about what might be the impact. It is not in anyone's interest for suddenly Southampton, for example, or Portsmouth to be completely overwhelmed. That's not going to help anyone. So we, certainly as the ICB, need to think about the whole system's healthcare, and Hampshire Hospitals, working with the ICB, we're working with all of these other providers to think about if there is more flow to Southampton, then there might be other things that actually moves from Southampton to somewhere else. So thinking about all of that and how we work with the community as well.
Thank you. Councillor Williams.
Councillor Brooke took my first question actually there, because I do represent Bishop's Waltham and know the impacts on QA. But I just wanted to touch on the location itself that you've chosen your preferred option. What happens if you're not able to obtain that site because you currently don't own the site? What happens if you're not able to get that site? Does this whole process fall apart?
Yeah, so I can pick that up. So we are in a process of negotiating what's called an option to buy. So rather than actually buy it, we can't buy it until we've decided whether it is the land we want to build on, because that would be a waste of public money if we then decided to move somewhere else. But we can get an option to purchase. And we've been talking to the landowners actually for a number of years since this process, and we're very confident that that will work. There is also a second plot of land in a similar area if everything, if it all went wrong. So, but still quite close to Junction 7. So we're very confident that that would work out. And at the moment, the conversations are just the commercial negotiations about at what price and with what services built in. Ideally, we buy land that already has, the landowners have put in the electric and the sewage and the water, and we're not trying to do some of that. So those are the kind of details that we're talking about at the moment.
Councillor Bolton.
Thank you for the presentation. It was fascinating, and the documentation that came with it, very interesting. Just to clarify, one thing that concerns me, because I represent a ward that is a deeply district ward, we're probably the furthest east of the whole district. And so a lot of my residents are concerned about blue light times. Now, when I read your document, I didn't interpret the bit that you mentioned, blue light and emergency car journeys. I didn't interpret it that way. I interpreted it as just meaning sort of people driving to A&E, the acute specialist A&E. But what concerns me is when you have, someone at various points within the district, has any study been done to work out exactly what the change is in blue light times and whether there's restructuring of the ambulance service required to make sure that you've got quick access and you can scrape them up off the ground and take them to the best location? Thank you.
Yeah, so just picking up the ambulance time. So a lot of work has been done with the ambulance service. So they've got some very good modelling software that we've been using with them to look at the impact of changing where the patient needs to go. So the change to the hospitals and looking at where the patient comes from, because they don't always have their falling over and need scraping up at home. It may be out and about. So absolutely. There's also impact of where you put the ambulance station and how many vehicles you have. So in their modelling, we can add all of that in. So we've been doing that. We've also done a piece of work that's looked at thousands of ambulance conveyances to the hospitals and looked at with a group of, so we've gone through a process that actually they've done in Dorset, but they've also done in Kent to look at, so this happened now, they went to this hospital, in the future they'd have to go to other hospital, and a group of clinicians who are not involved in the project have sat and worked through what might have been the impact of a longer journey time and where would they have had to go. And that has been very reassuring, hence Alex saying we believe that this is safe journey times for our catchment area.
Yes, Councillor Bolton.
So on that score, the ambulance service, will they be receiving additional budget from this proposal to bolster their requirements? Because there looks to be, from what I understand, there'll be increased transfers between sites depending on the option, and that will take up a lot of their time. And so I'm keen to know that within this programme, there's thought being given and funding for bolstering that service. Thank you.
So should I take that? So the capital funding, the 700 to 900 million, is just for hospital building and the refurbishment of the Winchester Hospital. So it doesn't go into any revenue funding. But as a system, we're investing in the ambulance service all of the time as other investment happens, and they are looking all the time at how they modernise their services. So actually, how they organise things does change all the time, but they've been very much part and continue to be part of this. So as a system, if actually the capital funding for the hospital is coming from the new hospital programme, there will be funding available that might have gone to Winchester's electrics or Basingstoke's roof or whatever that actually could then be reinvested. So that's how we're thinking about it. And I think the other important thing while we talk about ambulances, and people have mentioned the pressure on the ambulance service at the moment with queuing of ambulances, is not anywhere where we want it to be. And one of the really important things we believe in this new model is that when the ambulance gets to the specialist acute hospital, they can hand the patient over very, very quickly, because the flow will be much improved. It will be the right size, the location of the unit and all of the requirements will mean that we're not holding ambulances outside hospitals. And that's the same hope. People have mentioned QA, because QA has a significant investment, as you'll know, in their new ED, and the whole idea is to improve the flow of patients so that ambulances aren't held, and that will make a massive difference.
Okay, I think next up we have Councillor Brophy.
Thank you, Chair. I just want to pick up on Councillor Bolton's points about travel times and concerns, particularly about areas deep in the district as he describes. I just want to understand a bit more about how you are modelling some of the average times, because what the averages all look very reassuring, but the maximum travel times leap out like a sore thumb. I don't know where you'd have that thumb treated, presumably an urgent treatment centre. So if you're looking at an average and you have a large population centre like Basingstoke, which is much bigger than Winchester, would all the results flatter somewhere closer to Basingstoke inevitably, or are you doing anything in order to weight it so that you have the edge cases or the areas on the edge of the district or the catchment just as well cared for? On average, we might all have better outcomes, but if that means that a certain amount of people in the edge cases have absolutely dreadful outcomes, is that the calculus that you're making? Because I think that's the kind of thing that people who consider Winchester not on their doorstep, they consider that a long way away, are immediately looking at these plans and essentially can't get past. And I think understanding how you're calculating those averages and also mitigating the risks in those numbers would be really helpful.
It's a really good question. We have spent hours on travel times because, so first of all, you can, the blue light is considered equivalent to a off-peak. So if you're driving yourself at 2 in the morning, you get there in about the same time as a blue light can get there in rush hour. So that's one of the things we look at. So we look at off-peak and peak travel times. When we looked at we looked at who has used Winchester Hospital, for example, and the trouble is you then discover that somebody used it from Bournemouth, and you think, well, okay, now that's going to be really long to go, but not very many people use it from Bournemouth, but a few do. So you then start looking at, on a postcode district area, let's take a postcode where more people used Winchester than used Southampton, and we'll worry about that rather than an area where a couple of people used Winchester, but the vast majority used Southampton or Portsmouth or whatever. So when we were trying to decide what catchment, that was tricky in the first place, because we were like, if we take everybody that's ever been to Winchester, some of them seem to have come from an awfully long way away. The other issue being that, as Lara said, we have people's home postcodes. We don't necessarily know where they were when they had the event that took them to hospital. So they may have been shopping in the Christmas market in Winchester, but they live in Bournemouth. But we've suddenly got a Bournemouth resident using Winchester. So we had to kind of say, we're not going to use the complete catchment because we think some of this is not very helpful. So we took 95%. Was one of the things we did, and said, let's make sure we've got 95% of the people who use Winchester, and then let's worry about their travel times. And what you see in the maximum travel times in the document is assuming that all of those people still choose Hampshire hospitals, whether that's Winchester or Basingstoke, but depending on the service. But we also know that the people who are on the fringes, for whom then QA is closer or Southampton, probably won't. So that maximum travel time assumes that they stay with Hampshire hospitals. And what we tried to test was, is that safe? Because that's almost a worst case scenario. in reality, they may choose Southampton if that's closer, but then that'll be a shorter travel distance. So we tried to be robust to let's look at a worst case scenario around travel times and make sure that people are still safe. But it has been a huge amount. Yeah, go on, Caroline, say a bit more. We've spent hours trying to work out what population do we look at, and yeah, how to.
And within that as well, we're also we've done some analysis, and we will continue to do further analysis on particular population groups as well, because as you say, there might be disproportionate effects on people who have a particular demographic or socioeconomic needs. So we are able to break down through some of our information we have around our populations to look at that on a what we call, without getting too technical, the lower super output areas. So we can model at quite a sensitive level, and averages are difficult to come to, but at some point we need to make a broad assumption. But the really important piece that you talked about is mitigations. So what are some of the things that we would think about then that would mitigate some of the impacts on those populations and those areas? And a lot of that comes through what the new services could look like in the future as we're starting to invest in that. So how much can we do close to people's home? How much can we do in the community? How much of that rapid response means that people don't need to go near a hospital in the first place? So all of that starts to come to bear on it. But just in answer to your question, we are able to model down and look at particular populations in each of these options too.
Over that? No, sir. Okay, I hand over to Councillor Morris.
Yeah, following on from Councillor Brophy's questioning, I'm just looking through the integrated impact assessment with great interest, trying to find any sort of mention of response times, and that isn't mentioned in the document at all in any way, which is of great concern because, as Alex Whitfield mentioned, particularly with things like strokes, there's a thing called the golden hour, and every minute is essential. So my question is, what modelling has been done on how relocation to Basingstoke of the emergency service will affect on ambulance times? Because it's easy to imagine at peak time, all the ambulances will be in Basingstoke. So I want to ask if there's any modelling, would it be things better, worse, about the same, or we don't know yet?
So if you take something like stroke services that we currently only provide in Winchester, the population as a whole, because Hampshire Hospitals looks after people up in Newbury and Alton and Andover, by moving that service to Junction 7, both the average travel time to a stroke centre comes down because it's more central, and the maximum travel time to a stroke centre also comes down because actually the people who currently live in Newbury or towards that area have an awfully long way to get to Winchester for their stroke care today. So we've done that for every kind of presentation. What's the impact on maximum travel time? What's the impact on average travel time? The thing we find is that, as we've just discussed, if you live in Winchester, you're not very interested in the average or the maximum. You're interested in what's the impact for someone in Winchester. And for someone in Winchester, the travel time's just gone up. But when we look at the whole population for stroke, and we look at the neighbouring stroke centres, actually what our move to Junction 7, or I think even Basingstoke North, but I'll need to triple check, is it reduces both the average and the maximum for the whole population to both Hampshire Hospital Stroke Centre, but also to their nearest stroke centre. And does that make, sorry, if I not really...
that doesn't really address my question, because my question is not how long it takes people to get to the hospital, which you've covered in great depth and great statistical analysis. It's how long it takes for the ambulance to arrive at your home after you've made the phone call. And that is the response time in terms of ambulance to your home. How is that affected by the hospital being relocated?
Yeah, so if you call an ambulance, how long does it take to come? Is that... Yes, sorry, we misunderstood that. So something like symptoms of stroke is what we call a category 2 call, and the standard for response is to come within 18 minutes. So that's what the ambulance service tries to do. So when you said, sorry, now I'm understanding, the ambulances will all be at Junction 7 or at the Basingstoke site, that they may have taken a patient there, but the whole way that the ambulance service organises itself and where the ambulance stations are will impact on how long it takes. So they have to organise themselves to try and achieve this 18 minutes. And that's what they do. At the moment, the thing that stops them from achieving that is queuing at hospitals. And that's what we absolutely want to stop happening. But actually, it's about 50 to 60% of ambulances that go out take a patient on to hospital. The remainder can see and treat that patient at home or wherever they find them, and they don't have to convey them to the hospital. So it's important not to think that they're all going to be at the hospital, because the idea we're hoping is with the new acute specialist hospital, when they do take a patient to the hospital, they'll be able to hand over rapidly, and then they'll get back, and they will then, they'll move down into where the populations are. And that's how the ambulance service works it. And their shifts come on at different times, and how they organise where the vehicles is to achieve that response time.
Thank you for that. I'd like to try and move us on to questions around the nature of the hospital services. But just before we do that, I just want to pick up on two questions that were raised by the public. One was by, I think, from Philip Glassborough around the resilience question. If you have two different places and one of them goes down, you've still got another place. Whereas if you have one place, one A&E, and you're completely, declaring a critical incident and all the rest of the stuff, you've only got one place. So if you address that reasonably quickly, because I do want to get on to hospital services. And the other question, while we've been talking about location, and this I think was raised by one of the other public speakers, was why not Sir John Moore Barracks? Why can't? Why doesn't that meet your requirements?
Thank you. I'll talk about the resilience question. So I suppose the first thing that I put to consider is that to provide the services that you need to run an emergency department, it's not just the emergency department, it's all the specialist services behind that allow the emergency department to have sort of an undifferentiated attendance at them, to be able to then go and see a surgeon or a cardiologist or a stroke specialist or a paediatrician. So all of those services at the moment we're having to provide in two hospitals, except for the ones that we've mentioned, like stroke and cardiacs. But the majority we're doing twice, and so that already is a challenge from a workforce perspective to provide that in two sites. So actually, in terms of resilience, the purpose, one of the reasons behind thinking that centralisation of our most acute specialist services is the best way to go is one of the significant reasons is it does allow our staffing to be more resilient than it is at the moment to the vagaries of sickness and other aspects of providing workforce. So it allows us to have more consistent and sustainable rotas, for example, in all of those areas than we're able to provide at the moment. We do provide at the moment. We're very proud of our quality services at the moment, but it is difficult to do that. So I would say that there's much less chance of a centralised emergency department not being able to run from a workforce perspective.
Okay, and the Sir John Moore Barracks question?
Yeah, so we had a list of something like 30 odd sites at one point, and we went through a whole load of rationale and reason, and St John Moore's Barracks was listed in that. And what we probably need to do is give you a written response as to why that specifically didn't meet the criteria, because I hadn't recalled all of them. But the thing to say around and why not somewhere much closer to Winchester is that of all of our criteria, the one we were most anxious about was what the ambulance service wanted to do. Where could putting our acute hospital be that would mean that the ambulance service could hit the 18-minute target to get out to a category 2 patient who needs to have an ambulance within 18 minutes and get them to a hospital really quickly. And that junction where we've got kind of the A34 is not that far away, the A303, the M3, that, all those roads coming together, that was a really attractive site for the ambulance service. But we will probably put in writing, because we went through every site, and we'll come back and give the specifics relating to the Winchester sites.
Thank you. I think that will be helpful to all the people in Winchester who asked that question and who can't wade through the 900 or 1300 page document to see the reasons. Okay, we've talked quite a lot about location, and I have a number of people on the list. I think I would like to see if we can move the questions on to around services if we can. So who have we got next? Councillor Wise.
Thank you. In your presentation, you talked about the people turning up at Winchester A&E and how 2/3 of them could still be treated in an urgent treatment centre and 1/3 couldn't. I've got from the documents it was 60%, 40%. Could you kind of clarify which is the right number and expand a bit more on what's going to happen to those people who need it to be in A&E if they keep showing up there once it's gone?
So the number, so we went through a significant number of attendances at emergency departments. I think Lara described already. The number was around 60% of those that would be able to be treated in an urgent treatment centre. Now, the majority of those are, as we described, the ones who will take themselves or their family will take them there to the urgent treatment centre, and the care that will be able to be provided will be at the Winchester site. So the urgent treatment centre, I think one of the questions was, have we got an example of a local hospital where an urgent treatment centre happens that is similar to the services that we're considering to be provided in Winchester? And actually, unless Lara tells me otherwise, I don't think we have an exact replica. And the reason for that is because there will be a significant hospital with all its resources sitting behind the urgent treatment centre that will be developed in Winchester. So that takes into account all of the specialist diagnostic abilities that we're talking about. Also, one of the focuses for the Winchester Hospital will be same-day emergency care to be provided by hospital specialists like care of the elderly, frailty doctors, for example, who will be able to see patients that need specialist hospital input, expertise, investigations and treatment who don't necessarily need to stay in hospital for that. So this concept of having visits to the hospital on a daily basis, perhaps for that treatment, or what's described as same-day emergency care by the specialist teams will be provided at the Winchester Hospital and work very closely with the attendances at the urgent treatment centre. So there'll be still be a significant number of patients that will be coming to Winchester Hospital who have been referred there by GPs and others to allow that services to happen. I don't know if Laura wants.
Sorry, I was just going to add the Poole and Bournemouth reconfiguration. Actually, I can't tell you that Poole Urgent Treatment Centre is exactly the same plan as this one, but that is a very similar reconfiguration where they have got the emergency department at Bournemouth Hospital and Poole is the planned surgical centre. There is also an example up in Northumberland and that has again a centralised acute hospital with the planned surgical centre. So those are some of the models that we have looked at. And Dorset, we've been talking to Dorset because they're slightly ahead of us. So things like the case review of the ED, the ambulance cases that I mentioned before, actually they talked us through the methodology for that. So we used that because it was really helpful. And actually we asked one of their clinicians who've been involved to be part of our team on that.
Sorry, could I just add, because I think there's a thing in your question as well about this anxiety of what if I'm at the wrong place? What if I arrive and actually I should have gone to the other one and suddenly my care's delayed and I've got a problem? And I think we had a bit of that from the public. And so I guess I want to provide a bit of assurance. So for a start, if you turn up at an urgent treatment centre and have a cardiac arrest, there are resuscitation skills in every hospital, and you know they will sort that out. We also have I want to say well practiced, but it doesn't happen all the time, but it happens quite regularly that somebody will be in a hospital and we will recognise that they need a different hospital's care. So Southampton Hospital is what we call the tertiary hospital for us. They have things like neurology, brain surgery. We don't do that. And so if you're at either Winchester or Basingstoke and they suddenly realise actually what we need is the really specialist services at Southampton, then the ambulance service will move you to Southampton. That happens today, and those processes would still be in place, and they're well understood, they're safe, and that's how it works today. So when we've looked at it, and our clinicians have looked at it, the benefits for an urgent treatment centre of rapid response for most people who are not in a life-threatening situation but want urgent care, there's huge benefits. We need to make sure it's safe for the very small numbers who may end up in the wrong place. But it happens today, and we know how to do that today.
Supplementary? Yeah, sure.
Yeah, I think the worry is about patient transport, though, which is quite strained already. And I know from my family's experience, there's some long waits. There's sometimes taxi drivers and stuff that will not stick around for your whole appointment. I think that's the worry, is people keep turning up at Winchester and then being told, right, it's fine, we'll organise patient transport for you to go to Basingstoke, and that's not always a great experience. So are there plans to kind of improve the patient transport system?
Yeah, I mean, just for clarity, outpatients will still be happening at Winchester. So really is the emergency unplanned. And if people, I mean, at the moment, having a taxi waiting for you when you're in the emergency department, you're waiting a long time if your case isn't an emergency. So I understand your point, but I think for planned care and for outpatients, for scans, blood tests, that will all still happen in Winchester.
I don't think that's the question that Councillor Wise is asking. I think he's asking, for example, if I turn up with a baby who is younger than 6 months old with a fever, I've got a taxi from my home to take them. They're not really ill, but I'm a bit worried about them, and it's Sunday night and I can't get a doctor's appointment until Monday. I think it's the pre-consultation business case says the UTC won't see them, that they should be seen at A&E. So what happens to that mum who turns up with the baby at 8 o'clock at night in a taxi? How do they get told you have to go to Basingstoke? Do they get transported to Basingstoke? What happens?
Yeah, so that does occasionally happen today, that someone turns up perhaps. So I think what would happen is there'd be a discussion about the best way to get them to where they can be seen. So that might need to be transport if they've come in a taxi. If they've come in the car and the baby's stable, they will be assessed as to whether they're well enough to take themselves. So in the same way, at the moment, not a baby example, but if someone attends Winchester and there's a concern they might be having a heart attack, they are transported as quickly as possible up to Basingstoke.
I think the difficulty is identifying that 40% of people who currently attend the A&E, a proportion of those are going to be critically ill and require that proper the proper A&E treatment. But a large proportion of those people, children who've had a head injury, they've fallen off the playground, they're not particularly ill, but again, they've been told that you have to be seen by a doctor. The school's called and said, pick up your child, take them. Again, to go into Basingstoke for someone from Winchester is a really long way. So what happens with those people? Who else is in that category of they're not the really ill people, but those people who would expect to be seen at an urgent treatment centre and for whatever reason can't be, because that's not the clinical model that's proposed.
So, I mean, in terms of the children, there will be doctors and nurses trained in assessing children in the urgent treatment centre. That's absolutely the model. And as described in the pre-consultation business case, the expectation is that we will still continue to see children with minor illness and head injury. If they then require a longer period of observation or they require inpatient care, then yes, that's when that would be we'd be talking about needing to transfer them to the acute specialist hospital where inpatient paediatrics will happen. But the immediate assessment and, if necessary, resuscitation of a child, if that's needed, will absolutely take place in the urgent treatment.
And what are some other examples of the 40% that are not in that critically ill category but would expect to be seen?
So patients with an acute appendicitis perhaps who they sometimes might be able to walk in with difficulty, but they do that. So it's that sort of situation where you might need emergency surgery. I mean, one of the things that we're actively working on now as a health system, and we hope will continue to develop actually, is a reduction of people who walk into unscheduled care or emergency care services. So we really do want to encourage people. I don't know if Charlotte wants to come in a minute from a GP perspective, but we want to encourage people to access support from their home by 111 website, by telephoning, or through their local GP services or others, who will then be able to advise where best to go. So we really do that. The whole model of care even now is shifting towards that, rather than that sort of unheralded attendance.
I think it really involves not just patients getting their advice from the urgent treatment centre and us all being involved in triaging patients. So that's whether that's via 111, whether it's via your local GP surgery or the out of hours. I think it's really, really important, as you say, to try and get the person to the right place at the right time. But there will be sometimes where, with the best will in the world, and children get ill very quickly, don't we get that wrong. So then the urgent treatment centre will absolutely be able to look after and stabilise the child, but there will be situations where we'll need to move them to a better, safer, longer term place. But I think we all are very much aware that we need to try and work with patients, their families, to try and make sure they get to the right place first, rather than be transferred between.
Thank you. I just want to let councillors know that we have a number in line. So we have Councillor Williams, Councillor Brooks, Councillor Brophy, I think that's Councillor Wise, Councillor Bolton, and Councillor Morris, in that order. So if you're getting anxious that we're not getting to you, at least you know the order it's coming at. So Councillor Williams.
Wonderful, thank you, Chair. I have three questions, one following on from what the question that's just been asked and was brought up by Councillor Horrell right at the start of the meeting. What type of doctor will be leading, running the urgent care centre? Are you going to be putting junior doctors there, registrars, consultant even, and how many will be there, GP perhaps even also? I think that's really important.
Shall I take that? So the plan is to have doctors that are, so they're not consultants in emergency medicine. They will be at the emergency department. So they will have generalist skills. So they might be middle grade emergency doctors, they may be general practice background, but they have to have the skills and capabilities to manage the urgent treatment centre workload. And they will work with skilled practitioners, as we have in the emergency departments at the moment. So we have advanced nurse practitioners, we have emergency nurse practitioners working with, it's a multidisciplinary team, but the doctors mean that we can treat a wider range of patients. And that's why we feel, because at the moment, the urgent treatment centres that you will find around Hampshire, and we have a number, not in this catchment area, but around Portsmouth and Southampton, they're different models, but we know that if they have doctors, they can treat that wider range. And they just, sorry, the other thing is they will be supported remotely if they need advice and things by the emergency department consultants. And that's really important. So if they're not sure about a scan, or then they need some advice, they've got that link that, and they can be supported.
Well, thank you. So registrar level care. You touched on what happens if a patient goes into cardiac arrest in the urgent treatment centre. What happens to a patient who goes into cardiac arrest in Winchester? Even if the patient is having the result of that cardiac arrest is a heart attack or major trauma, the current model where they would go straight to Winchester, stabilised, and then moved on to a trauma centre or cardiac centre, say Basingstoke. What happens to patients in Winchester and the surrounding area that are in cardiac arrest? Will they go to the urgent care centre? I doubt they will. And then what impact is that on their survival rate? Has that been looked at? And the wider survival rate of residents in Winchester?
Yes, so that is part of the work that we've done. So wherever you are, even now and in the future, the paramedics in an emergency situation like that will take you to the nearest place that can manage your care. So, for example, if you have a major trauma outside of Winchester Hospital, they will scoop you up and take you to Southampton because that is the major trauma centre. So already we sometimes drive past a hospital to get to the best place. So they won't take you to an urgent treatment centre. They will take you to where you're going to get the emergency medicine consultants, which when we bring those two teams together, we will have the consultants there for more hours and the infrastructure and the staffing there for more hours to get the very best care. Now, paramedics have significant training to be able to stabilize people to do that. And there are, as you'll be aware, there are fast responder doctors that go out. We've got the helicopter, there are many different things which are here today, but that will also play into that sort of scenario.
Okay, thank you. But there will be a delay for a patient in cardiac arrest under the new model of urgent care treatment centre, which is a worry to residents. And then finally, my last question was, I did see the letter that was published in the Hampshire Chronicle stating health bosses back UTCs over A&E. I was just wondering if you could touch on this a little bit further, and looking at all the signatories of that letter, there wasn't an emergency department consultant that had signed it. Would there be more weight if an emergency department consultant had signed that letter?
Good question. I mean, we do have if you've been to any of our other events, we quite often have the lead consultant for the emergency department who's there. We have one of the matrons there. They've absolutely worked on this model. So it's not my model, it's they've designed it. We're talking to you about it. And they've done the work to understand the staffing model, what they can manage and what they can treat. And they have been at many of our events in the last two Winchester face-to-face events. If you join any of our online events, they're quite often there.
I'm going to ask if we can revert to normal rules of one question, one supplementary. I'm just going to take the liberty of just asking a quick qualifier on, it's related to the nature of the services in different places. As things stand, Winchester is a centre of excellence for stroke care. I'm not sure if that's the right phrase, but it's certainly the place where stroke care happens. I think if I've understood you correctly, the stroke care would move to the new acute hospital. You're nodding and that says yes. And given we've got an ageing population, which I know applies to Basingstoke as much as, well, certainly as Winchester, what's the logic in shifting a centre of excellence from one site to another site? Just help me understand that. And bearing in mind that, it's well understood that for stroke care, get there within an hour, get treatment, and you have a much better chance of survival with minimal impact. From the point of view of Winchester, how does that look good?
So I could say as a non-clinician, but Bill Collins to come in there. I think there are two reasons. One is when we look at the map for the whole geography, as I say, it's great if you happen to be in Winchester, but if you live in Newbury, it's a very long way to Winchester. So moving it to a more central area, because we do provide care for that whole Hampshire Hospital's geography for stroke in Winchester. But the second reason is that having your cardiac service in Basingstoke and your stroke service in Winchester and your trauma service in Basingstoke and is not very coherent, and all of the clinical best practice models say doing all of those things in the same place enables, because actually patients don't come with a neat little label that says I've only got a stroke. People have multiple things going on with them at the same time, and if you're really unwell, having multiple specialties in the same location can make a difference to your outcomes. So those would be the two reasons, but I don't rely on it yet.
Absolutely. I mean, as an example, one of the complications of having a stroke is to have a heart attack, or to have a bit of your bowel that gets short of blood supply, so therefore needs an emergency operation. So, and you might need intensive care as well. So all of those acute services are absolutely relevant and would enhance the amazing care that we already provide.
If I could now call on Councillor Brooke. Thank you.
Thank you. And for your explanation as well on the combination of services, I was understanding it and I really appreciated it. It made a lot of sense to me. I wanted to focus a bit more on the home services piece because you sort of touched on that a few times and saying that that's going to increase. Why is it going to increase with the new hospital, and in what way? What sort of new things are you thinking you'll do more of in a home setting rather than hospital that you don't do currently?
Yes, I can. I think this is the way we're changing care already. I don't think we're even going to wait until a new hospital is built. So I think most people do better if they're looked after with the right care closer to home or in their own home. So a lot of the new models of care and what we can provide in the community with the support of specialists, and we've worked a lot with bringing together. We have historically worked very separately or been seen as separate, but actually I think we're all really trying to make sure that we work together so that we can give what primary care, and I don't mean just general practice, I mean our community pharmacies, our community nursing teams, we can provide an awful lot with the resources in the community, but we sometimes need a little bit of extra support and expertise and just talking together. So I think that's where we're developing our care already. We're using virtual wards and new technology to do that too. That doesn't mean it replaces when you need to see somebody, but I think it can be a real enhancement of keeping people safe outside of hospital so that we save the hospital admissions and seeing a specialist for where they really make a difference. So this isn't avoiding or getting a cheaper option in any way. It's actually about making sure that people are in the right place for their care and looking at still preserving some of those investigations and specialist clinics out of the main hospital in the communities with some of the expertise in the community is where we're already going, and I think this will enhance it.
May I ask a supplementary?
Yes, of course.
Having worked in primary care, it's very much them and us between primary and secondary care quite often, and it's really painful to get through. So I'm pleased to hear that you are working together on that. And very often I saw people say, I can't take time off work during the week, so I have to go to A&E at the weekends because I can't get a doctor's appointment. Presumably those people will now go to the urgent treatment centre, but how will you cope with that if you're doing the home services? I mean, rather than taking people to hospitals, that will only increase. I can't get time off work to have this home service. So is it that you will be removing some of these services to prioritise some things in the community rather than having them in the hospital? Or, you know, if you understand the question.
If I start and obviously bring in, I think the beauty about the urgent treatment centre is that that is a place where actually if you combine skills of people, we're very used to treating people without all the hospital services. We've got obviously colleagues who have the expertise of the hospital service. If you combine and make that it's a beautiful way to bring teams together, and then obviously recognise when the urgent treatment centre doesn't have what a person needs, and that's when the person is transferred. So I don't think it should split. I think it's an opportunity to bring together.
And just to add, I think we all recognise, and it was mentioned by a member of the public, that the hospital is that place of safety because they can't get the services that might be required in the community. And actually, we recognise that now, and the hospitals are caring for people who would be much better at home, looked after, and that would be better for them. It would be a cheaper way to provide that care. So we are now looking at actually there needs to be more investment in community and local care. And yes, less in the hospital if they're not having to be that sort of safety net or people are unable to be discharged at the end of their stay. So I think your point is really well made, and we're not waiting for a new hospital, but actually because we're thinking really hard about reconfiguration of services, this is when we've really got into this conversation about actually what really needs to be in this hospital. Because what's happened is hospitals have got bigger and bigger and provided more and more, but actually, as you will know, a lot could be provided out in the community.
Chair, I had a second question. Shall I wait and come back in at the end, or shall I ask it now?
Related, very closely
It's
related.
it's sort of.
Okay, can I put you on the list to come back in? I'm aware we could probably talk all night about all the different services, but I'm sure we've all got other things we need to do eventually. So I'm going to take the next question from Councillor Brophy on whatever you were going to raise, but then I'm just going to ask if we could perhaps think about moving on to okay. I'm going to just ask if you could consider moving on to things like finance and security of that and risk. But I will, for those that have a particularly burning question they want to ask, and you've got your slot in the list, you ask the question that you wish. It's just a request. Okay, thank you.
Thank you, Chair. Actually, we've all been talking a little bit about the dynamism of certain situations and also speed of response being very important, the combination of services. I wanted to turn to the maternity unit and the changes proposed to Winchester to a midwife led maternity unit. This was 11 years ago, but when my son was born, it was a glacial process over several days until it wasn't. And then it all got very exciting, and a lot of specialists were involved. So I suppose the question is that a lot of parents will be concerned that they'll be in one context of birth, and then suddenly need to be escalated to another situation. And we've all talked about that kind of process of escalation and the established pathways that you have in place. But should you need to transfer to an obstetrician-led process or an operation, would that extra 20-minute journey somewhere else, or would it be to Southampton? How would that be handled, and how would that impact the outcomes for children?
Thank you. Totally understandable question, and recognise that the importance to get this right. Absolutely. So I'll answer it in two ways. One is in the concept of choice, and the fact that more and more we want to start discussing the concept of where a mother wants to give birth to her baby from the very start of their journey in their first appointment with a midwife. And that obviously is not a fixed point. That discussion goes on all the way through, and as you go through your pregnancy, whether it be standardized or complications arise as part of it, that will then influence the decision-making process. But one of the most important things is that the family, the mother, understands the risk-benefit ratio of any choices that they make in relation to where they're going to birth their baby. So one of the big advantages, I'll come on to the maternity unit in Winchester in a minute, but one of the big advantages that we really feel is a huge enhancement to our services across the whole of Hampshire hospitals that this allows us to provide is an alongside midwifery-led unit. So for those mothers that do want to be in the environment of a midwife-led unit, less medical, less clinical, that will be provided in Winchester, but also on the new site alongside a Basingstoke site. So for those who are concerned about the risks of them needing medical intervention, then that might well end up being their choice of birth. In terms of the decision making around and the concerns around having to access help immediately when you're in a midwifery-led unit, this is something that is it happens across the country at the moment, and there's increasing knowledge and understanding about how early you need to seek that help to allow you to make that change of place of delivery. And again, not only during the pregnancy itself, but during labour and when you're in the early stages of labour. At the moment, we have a centralised service called Labour Line, where ladies will ring and the decision will be made about where and when the best place to start having your hospital visit, if that's where you're planning to have your baby, should be. So they will be there with the mothers at home making the decision about where they should go, in association with their birth plan that they've made with the midwives. We currently have a midwifery-led unit that runs out of Andover. It'll be a lot smaller than what's planned for in Winchester in terms of numbers of beds and deliveries that we would expect to go through that. But that runs a service at present, and as we also give the choice of home births as well. And we feel that in the context of the services that we provide in maternity, that we provide well-staffed, excellent care at the moment, and that this will be an enhancement to that, rather than actually taking away the services that we can provide to the mothers.
If I may ask a supplementary.
Yeah, just one.
Can we understand that it'll be a smaller percentage of births that would be appropriate for Winchester, given that risk ratio that you referenced? I mean, also, is it possible to understand which services would be available? So antenatal care or scans would be available in Winchester, or if you needed an obstetrician-led birth that had happened in Basingstoke, could you still get some of the antenatal care in Winchester? So I think that's a concern that people do have.
Thank you. Very good question. Happy to clarify. So all of the outpatient services will not change or be enhanced than what we can provide at the moment. So the obstetrician-led, antenatal clinics and midwifery-led antenatal clinics will not only happen in Winchester, but across the around in the community as well. And we're actively looking at the moment about where we can then enhance our care for perhaps patients that even find it tricky to get to Winchester Hospital within the Winchester population, and seeing how we can enhance their care. So absolutely, all the antenatal visits and scans and investigations like the rest of the hospital will continue to be provided where they are at the moment. The change will be purely with that where the obstetric labour ward care will happen.
I think next up I've got Councillor Wise.
Great, thank you. One of the big challenges you set out is that you can't have two services in two places and split your workforce. And I wonder how you're going to retain the workforce you have in Winchester who are not going to be able to get to Basingstoke. So either people that live in Eastleigh, they're not going to be commuting to Basingstoke, they're going to work somewhere else, or people like in my community who don't have a car, they're not going to be going to Basingstoke either. How are you going to make sure you keep those specialist staff when you move their place of work?
Yeah, it's a great question. So retention is absolutely crucial to us. So the first thing to say is that retention for different people is different. So what we thought about with the workforce is we have had a number of people join us over recent years because we're getting a new hospital that they're really looking forward to being part of designing and building. And the new hospital programme is all about ensuring that there's really good spaces for staff, as Nick was saying, good rest areas, nice fresh daylight, all of the things that sometimes, one of the staff briefing events we said, what do you want in the new plans? She said, I don't want to have to sit in a cupboard all day, because that is what some of our staff are doing at the moment, because we're so short of space everywhere. So for some staff that will be exciting enough and important. For some staff, I was out in one of our maternity services on Friday, and the neonatal teams were saying, we are so looking forward to the point where we've actually got a combined neonatal service that can look after the smaller babies than the ones that we're currently able to look after. And that will be a real retention pull for some people. Other people, I want to stay working at the Royal Hampshire. I drop my kids at the nursery next door, or that's a really important thing. And the reality is that the Royal Hampshire County is going to be a significant size hospital with a lot of jobs for a lot of people. And so one of the things we're going to be working through is when we get much closer to the build and the opening, is individual by individual, what is important to you? And there will be plenty of people who will carry on doing the same job in the same place, because we've said most of the services will still be in the same place as they are today. And there are other people who will have a choice of saying, is it more important to you to stay in the same place that you're working, or to stay with the same service, which might be moving? If you want to move, how do we support that? So today, we run a shuttle bus between Basingstoke and Winchester for our staff today. I could absolutely see that we would continue to do that kind of thing in order that staff could, if they wanted to move with the service, stay in the same service, and we'd help them get to work. But it's different for every member of staff what drives them to stay or go.
Got supplementary?
That is very good, but obviously the issue was that you're splitting up specialists if you try and keep two services open. So are you concerned that there is that risk that actually you move, for example, stroke to a new site near Basingstoke and find actually, you maybe lost some of your workforce because it's just too far away?
I think it is a risk, but I think that working with our colleagues about what is important to them as an individual, we absolutely want to retain all of our staff. I mean, we saw it a bit with some of the trauma services in Winchester moved up to Basingstoke quite a few years ago, and some of the ward-based staff said, actually, I want to stay in Winchester, but I'll work on the planned orthopaedic ward instead of the trauma. And some said, actually, what really matters to me is trauma, and I want to move. And we just worked with the individuals to kind of work out what was right for them. So it is a risk, but I think most people will still be providing the same service in the same location. So it's a small number of our staff that this impacts.
Thank you for that. You mentioned there'll be a lot of staff still at Winchester. Could you give us some idea of the numbers now and the numbers after they change? Just roughly ballpark figures. Are we talking about more, less? And if so, 10%, 25% shifts?
I mean, we might need to come back to you on that because I don't think we've worked with the detail of the workforce planning is kind of in the next phase. But at a really high level, I think it will be about the same would be my thing. It will be different staff because the planned, for example, the 2 extra theatres we're opening building this year, opening probably early 25 for orthopaedics. That's got a huge number of extra staff coming to Winchester to do that. But the emergency department staffing numbers will be lower because the urgent treatment centre won't require quite as many staff as emergency. So there'll be ups and downs, and I don't think we've mapped it all through yet.
I understand that, but I think it's helpful to people who might be concerned about radical changes to at least have a ballpark understanding of it. And it affects people's lives, it affects the local economies, particularly in some of our slightly more deprived, I'm not sure if that's quite the right words, deprived areas of Winchester. We do have them. Next up, I've got Councillor Bolton.
Thank you, Chair. Just first, I'd like to make sure that I understood the debate with Councillor Williams and yourselves correctly, because he concluded that the changes to Winchester Urgent Treatment Centre would result in cardiac trauma times being longer, if I understood that correctly. And my understanding is that that is very unlikely to be the case because it's currently at Basingstoke and the options of M3 Junction 7 would be closer on average to everyone in the district. So I just wanted to make sure that
Yeah, just cardiac arrest, not so trauma cases.
Could you put the mic on?
Sorry, just to clarify, it was cardiac arrests that I was specifically talking about, not trauma.
Would you care to comment on that? Yeah.
Yeah, so I answered specifically around cardiac arrest. So just to be clear, that is when your heart has stopped. So you have in effect died. The paramedics are resuscitating you on the journey to the hospital. Sometimes they would try their absolute best to get to the hospital. I think the question was, would they, in that resuscitation scenario, go to the urgent treatment centre? And the answer is no. Unfortunately, if you have an out of hospital cardiac arrest, your chances of survival, as you'll be aware, are slim. That's why we have the defibrillators all around the community now, because your best chance is early defibrillation. And then you need to get to the cardiac centre. So if they have managed to defibrillate you, they need to get you to Basingstoke now, if that makes sense.
Thank you for that, Claire.
So time shorter. Okay, thank you. So in your presentation, you mentioned about step down services led by nurses, which, if I understand correctly, is taking patients from acute beds and they're being treated in beds that are they're not then, as we call it, blocking patients receiving acute or trauma treatment, etc., or surgical treatment. In the proposal, it seems to suggest that that will be more centralised around Winchester in one of the options, and option 3, it's remaining at Basingstoke. Has any consideration been given to this being located at all sites, because it would enhance the ability to get patients through the system? Thank you.
So there are 2 distinct step down bed groups in these models. So the first one in Winchester actually isn't just nurse led. The anticipation, this is people who still need some degree of medical treatment, but they don't need the very specialist heart set up in coronary care or the surgeons, but they still need doctors there. And then the Basingstoke beds that you mention, that is very specifically nurse-led. So there would be a doctor around, but less intensive medical support. So your question, have we considered, and actually, you know, we're seeking feedback. So if your view is that would be helpful. I think the concern about having them at the specialist acute hospital is that's where we want to put the intensive, particularly medical support. So actually the step down beds, we want intensive therapy support. We have doctors and nurses, of course, but we want to make sure that we're not trying to do everything everywhere, if you see what I mean. So, you know, we're interested in views if that's what people think. And some of the iteration of option 3 has come from listening to public feedback about, you know, actually, if we live in the north of Hampshire, our step down, we want it to be more local. So, you know, please give us that feedback if that's important. But I think the idea of having them in the specialist acute hospital probably is contradictory to our trying to get the acute services together.
Councillor Morris.
Thanks. When I moved to Winchester in 2014 as a good civil-minded citizen, I went to a consultation about the building of Basingstoke Hospital. That's 10 years ago, so you might understand I'm a bit cynical about the whole project. And the promises of politicians have a habit of melting away like morning dew. So has the Treasury guaranteed full funding for the entire project?
It's a very topical question, isn't it, at the moment? So where we are is that the National New Hospital Programme has a very clear budget up until 2030 and then has an indicative budget beyond that. And we got a letter in June, beginning of June last year, from the Department of Health and Social Care saying our envelope for the Hampshire project is between 700 and 900 million, and we should progress to develop plans, ideas, talk to the public about them. We have been funded to do all of that by Treasury, so they've given us the money to do that in order that we can then write an accurate business case about what the money is, how much money we actually need to do that, which until we've decided on a site and a model, we can't be specific about exactly how much money we need. And to go through the development of the business case so that that business case can go to Treasury, where there is an indicative envelope ready and waiting for us to put in our pitch to. So that is the situation. We've got a very clear letter saying 700 to 900 million for Hampshire. Can you get on and work on the business case so that we know exactly how much you need?
So I understand that you're working on the business case. In your consultation document, I read with interest that you're currently being underfunded by about £83 million a year, and you have the staff shortage, which is joking, where it's simply not being enough doctors in the service. Would I be right in characterising your opinion here, your attitude here, of going, you're assuming that the underfunding of the health service and the staff shortage will be here to stay until 2030, and you are in effect working on a worst case scenario for the health service?
So that's the revenue side of the business case. Is that what you're referring to, rather than the capital in terms of how much money so the revenue side of how much money we spend every year on staff and in order to run the health service? Is that the side of it that you're looking at?
One of the reasons
Yeah.
you're giving for this project is you say that you are £883 million debt. So if the health secretary suddenly said you can have more money, you can have £83 million extra, the reason for this hospital would go away, would it not?
Oh, absolutely not. Because actually what we want to do is provide the best clinical care for the people of Hampshire. And this is what we are trying to do through this proposal. So the fact that this improves patient outcomes, improves the care that we're able to provide, and it enables us to spend taxpayers' money more efficiently than we currently are, is that they're all positive arguments for the proposals. The reality is that we cannot continue to spend more money than we're allocated by government for health services in Hampshire. We have to live within our means, and we don't want to do that by compromising the quality of care in any way. We want to provide the very best care we can for the people of Hampshire. And we have lots of programmes that are running right now before the new hospital opens to close that gap. But we know that reconfiguring our services in this way will enable us to provide more efficient care as well as better care. So it's not that we're not doing anything until the new hospital opens, absolutely not.
If I could just interject on the funding topic and the security on that funding and dates on that funding. I had a look at the Public Accounts Committee meeting that happened in September, and I would say that and this is the Public Accounts Committee that was reviewing the new hospital programme, which originally was around 40 hospitals, I think. And it's been, it's progressing, but I think I would characterise the opinions of several of the members, Anne-Marie Morris, Mark Francois, of all people I found myself in agreement with, and our own MP, Steve Bryan, as sort of raising substantial concerns about the ability of that programme to actually deliver what it's claiming it will deliver on time by 2030, and with raising a lot of concerns about whether the new hospital 2.2 architecture is ready in time, and hence that leads on to concerns about whether the Basingstoke Hospital, which is in the sort of fourth cohort, I think, and whether realistically, is it really going to happen in 2032? Is the funding going to be there? Is the model going to be there? Are the people who can build this stuff going to be there? Can you sort of reassure us, or at least comment on that? I appreciate a lot of those things are way outside of your responsibility, but to me, it raises concerns that we're looking at 2040, 2045.
So yeah, there's quite a lot of aspects to that. The first thing I would say is we in this team are actually committed to doing everything we possibly can to make sure that Hampshire gets new buildings, because we know how desperately we need new buildings in Hampshire. So we are working incredibly hard to make sure that we progress all of the different bits of work that have to be progressed in order to get the business case, in order to keep things moving for Hampshire. The Hospital 2.0 is really interesting. So we are part of the national programme, and one of the things that they have promised from the beginning is that because we are building multiple hospitals across the country, we won't have to rework the designs of an operating theatre or a ward layout, because actually that will happen once centrally, and then the modules can be built in a kind of mass-produced IKEA kind of a way, and that will mean that we're not wasting time deciding where plug sockets need to go, because that's all been sorted out, that the manufacturers are able to have a long-term commitment and manufacture the various components, and that therefore by the time they get to us, as towards the far end of the programme, this process will be up and running and working really well. Now that is the intention of the national programme. What we've said is we just need to do everything we can in our power to make sure we are not delaying any of the steps in the process. The other bit about the building, because there have been a lot of questions about there just simply aren't enough builders in the UK to build 40 hospitals in 10 years, or what is now 6 years. So one of the things that our team talk about is that there are a very small number of companies that can build big, tall buildings. There are a lot more companies that can build 2-storey or 4-storey buildings, and that if we it's one of the pros and cons of the current Basingstoke site versus the new site. If we can build a hospital that is not as high rise and is more modular, then there are a lot more construction companies that we can access to do that. So that's one of the things we're looking at is, you know, actually it might be better if it's junction 7, it might be better from a visual point of view anyway and a planning point of view, but it also could have an advantage that we're not trying to compete for a very small number of companies.
Yeah, thank you for that, and it was helpful understanding the some of that distinctions there. I mean, I totally understand that a lot of that is outside of your control, and I think we, you know, commend you for entering the process, even though there's a lot of moving parts there, and it's very difficult for you guys to be at all certain about when funding might happen and all that sort of thing. But thank you for explaining that. Next up, I have got Councillor Brooke, I think.
Thank you. So my second question from earlier, it sort of relates to what Councillor Bolton was saying as well. You mentioned in the original information we had about how it's got the support of social services as well. And the option 3 was that wasn't the preferred option, also talked about the reablement. So people who, you've already said about the step down, the nurse-led piece, is that in some way trying to fill the gap between you're kind of ready to leave hospital, but you don't have somebody to look after you? That sort of rehabilitation centre piece almost that we used to have that disappeared. Is it almost trying to fill that gap, or how will that work alongside social services trying to sort of fill that? Off you go, you don't need to be in hospital, and then going, we don't have a care plan.
Yeah, good question. So in the option 3, those beds, the reablement beds, I guess, sorry, I should come back a minute, because really, if people can be at home, they are best at home. I think we all accept that. But there are some situations where they actually need some reablement in order to, before they can really be at home. So that would absolutely fit there. So it's not replacing social care. It's while they understand the care that they require and that's put in place. So that's the Basingstoke beds. In the Winchester step down beds, it is ongoing medical care as well as intensive therapy and things like that, because really we want to, some people need bed-based reablement, so they need an inpatient setting, but we recognise that that is probably the narrow number. There are many more people that need it at home, because actually just the nature of living at home, you do quite a lot of your rehabilitation because you have to get up and do things. So there's a bit of a balance. So there is a need for bed-based, and that the Basingstoke beds would help with that. What in the options in the model, we've tried not to you know, the reason it isn't our preferred option is because, as we've mentioned, it does split that workforce again overnight. And running a day case centre is very different from having to staff 24/7, 7 days a week. But you know, we do recognise that there is a need. So that's why it's not, option 3 isn't our preferred option. So yeah, hopefully, does that answer your question?
It does, but if I may ask a supplementary, I'm aware that the NHS were paying care homes to take people that weren't quite ready to come home, but rather than keep them in hospital, which of course is far more expensive than including it in the planning stage when you're building a new hospital. So just to re-clarify, does that take away from that we need to put you in this care home for several weeks and the NHS are paying for it? Does it take away from that and move that back into the hospital, or is that still a thing?
Well, it's a good question. Probably it should do, but I think whoever's paying for it, whether it's NHS or social care, actually caring for people in hospitals is more expensive than in nursing homes. The key about the hospital is having the therapy input together with the nursing care. And when people go to nursing homes, there is some therapy there, but not as much, not as intensive. So I think that's the big difference. So, you know, if we look at sort of the UK value for money, actually looking after people in hospital is very expensive if they don't need to be in hospital.
Thank you. I think we now have Councillor Bolton again. Sorry, if you. Thank you. In that case, I have Councillor.
Sorry, can I have one on
Councillor
hospital
Becker.
services? Is it possible for you to commit that you won't move any services from Winchester until the new hospital is built, given the time frame we're looking at?
So the first thing to say is that most of these changes we couldn't do in the current real estate. So actually the emergency department in Basingstoke is not big enough to take all the ambulances that currently go to Basingstoke and Winchester. So we physically couldn't do that anyway. To say that absolutely nothing will change for 8 years, I wouldn't want to give you that commitment, because I think if new innovation comes in and there's new opportunities, then we would want to implement them, as soon as we were able. But the kind of set changes we've described here, we need a different building to do these. So, I'm always really reluctant to say nothing will change, because you never know what might come over the horizon. But these kind of changes, we need the real estate to do it.
But A&E and maternity won't be downgraded in the meantime?
We've got no plans to do it without changes to the real estate. I mean, similarly with the births, at one point we did look at, could either the existing Basingstoke Hospital or the existing Winchester Hospital take all the obstetric deliveries, and we haven't got the space. So, yeah.
Thank you for picking up on that. So, Councillor Williams, over to you.
Excellent. It's on the finance topic, if that's okay. Yep. So it was in regards to a letter in the consultation documents from Lord Markham in regards to the conditions set out as part of the funding from the new hospital scheme. So condition 2, Royal Hampshire's Winchester A&E would not be affected. It seems to me, reading that letter, that as a condition of the funding from the new hospital programme, that condition has to be met. And under all 3 options, that condition that you're proposing, that condition to me doesn't seem to be met at all, because you're downgrading it to an urgent treatment centre, not keeping it as an A&E.
So we had a number of letters at different points in time that came out. So, and I haven't got all the dates in front of me, but around 2020 time, we had an initial letter that talked about A&E, talked about significant investment in Royal Hampshire, no changes to A&E, no changes to maternity. We then, as a result of things like the Ockenden Review and a whole load of service reviews around safety in maternity, we quite quickly got an update from Department of Health and Social Care that said, actually, if you can evidence that maternity safety will be improved, we would absolutely support changes that improve the safety of maternity services. And we then got another letter that said, we understand the urgent care offering. So what happened was we took a model with an A&E in Winchester to the Clinical Senate, this group of the great and the good clinicians in the South East. And they came back and said, we've got significant concerns about that proposal, given the other changes that are happening around intensive care, around children's inpatients, around other things. We don't think your full A&E is safe, because you haven't got all the other backup behind. It's not a coherent model. So we talked to the Department of Health and Social Care and said, we've got a conflict here. We've got a requirement that we mustn't touch at A&E in Winchester, and yet we've got clinicians telling us that this is not a safe model of care. And if an ambulance brings someone to Winchester and then you haven't got all of that backup behind, that's not safe for patients. So we wrote back again, and there's an exchange of letters that's happened that said what we're proposing is absolutely there will be an urgent care service in Winchester, and people will be able to go to Winchester for their urgent care needs through the urgent care treatment centre, through the same day emergency care. But we do not believe it's safe, and we're being advised by everybody that to try and maintain a full ED, full emergency department, wouldn't meet the current standards. And we got a letter back saying, absolutely understand your proposals and agree that the condition is around urgent care 24/7 in Winchester, rather than the A&E can't change at all from today. So there have been an exchange of letters.
Okay.
Supplementary to that, could those letters be made available at a later date to committee members? Because the letter that I saw is dated the 26th of June of 2023, so it's quite a recent letter. So I'd be quite keen to see further correspondence if that's possible.
Let me just check under what conditions we were sent them and whether they're asked to share or not, but we'll see what we can do. I don't know, Caroline came to ICB as well. We'll check.
Okay, unless anyone puts their hand up. Oh, you were very keen. Oh yes, sorry, Councillor Bolton, you had you deferred your question, didn't you?
Well, Chair, it looks as though we've gone free for all on any topic now. So
yes, I agree, Councillor Bolton, and it did slightly disturb me earlier on that that happened. So we've adapted.
In any case, so from what you've said so far, it seems clear to me that this is an independent consultation as part of the process undertaken by the ICB, funded by the government under the new hospital programme, and that the decision over the options presented and the feedback gathered will be made by the ICB in conjunction with NHS England at the spring decision-making meeting. And I want to get clarification from you that there is no undue political influence being put on you in that decision process, because Danny Chambers, the Liberal Democrat candidate that spoke earlier, is running a campaign that says that the Conservatives, i.e. the government, are axing A&E services. And I want to know if that's going on, because it shouldn't be. And I'd like clarification, please. Thank you.
I can pick up the one around the consultation and due process. So the consultation is absolutely focused on going out and hearing people's views. And, you know, as I said earlier, we've got an independent organisation who will collate all of the feedback. It's coming in through websites, it's coming in through these discussions, and it'll be fed back to us. In terms of the decision-making process, then all of that information will be collated together. We're obviously working with partners in terms of involvement engagement, because that's one of our channels out, as I talked about earlier. But the decision making is purely based on what comes back as part of that information that comes back from the public consultation, comes in terms of the clinical evidence, looks at the finances and whether they stack up in the workforce. So there is not a political element in terms of influencing what the outcome of that decision making process might be. And you know, we would be equally as, you know, unhappy about that as you would be. So it is absolutely, the consultation process stands independently.
Thank you. I'll send him an email letting him know.
Thank you, Councillor Bolton. Thank you, Caroline. I'm just going to ask a couple of questions which I think were raised by Councillor Wallace. And these are in my words, so I apologise to Councillor Wallace if I'm not asking them in quite the precise form. But on the carbon aspects, what analysis has been done on the carbon, you know, the usage of carbon in the new site versus the current sites? And in terms of the invested carbon, you know, we all think of money as the investment, but building a new hospital has a carbon impact. So I'd like to understand what analysis has been done and what's the return on investment. And kind of related to this is a question around travel, which if we consolidate our sites, inevitably, and maybe, you know, I understand the clinical model, I can see the advantages from the point of view of clinicians and so on, but that transfers an increased travel to people who need to visit hospitals. So people from Basingstoke will be piling down to Winchester for their planned operations and so on. What analysis have you done on the carbon impact of these changes? Thank you.
Yes, it's a really good question. So one of the things that's really I find really exciting about the whole National New Hospital Programme is that they want to build in carbon neutral from the offset, and are actually investing more money in order to do that. So part of the investment in the Winchester site is about decarbonisation of the existing hospital, which is much more challenging than starting with a new hospital and building it from the beginning with a carbon footprint in mind. So for the Winchester, there's the decarbonisation at Winchester, which will help. For the new site, it is, and I wish Shirlene was here because she knows all of the right words about it, is the built carbon of the way you build the building is absolutely being done with carbon in mind, and then how you operate the building. So our carbon footprint today comes from a range of things. So our buildings not being carbon efficient, and the heating and the cooling and that not being designed in that way. From the transport, as you say, and people getting to and from hospital, there's also a surprising amount of carbon footprint in the NHS from things like anaesthetic gases. It was one of the things that surprised me the most, is that actually they have a huge impact. And so changing to different anaesthetic gases, even things like Entonox in childbirth, if you can capture that Entonox rather than it getting out and into the atmosphere, that has a big impact on the environment as well. So building your building with all of that in mind means that you can make a big difference. And one of the aspirations that we've talked about for this programme is having a health campus with the new hospital, which has a focus on planetary and population health, and actually building a whole kind of academic infrastructure as well around this, and colleagues from Winchester City Council have been involved in some of those early conversations, and Winchester University and other partners. So the transport to and from hospital is only one component, I think is what I'm saying, of a whole range of things which contribute to the carbon footprint. What we do know is that one of the transport biggest impacts we had was when during COVID we moved a lot of our outpatients online. We saw a big reduction in our carbon footprint from transport because we were actually able to, people didn't even need to leave their own homes. They could have video consultations and such like. Now we've gone back to more face-to-face appointments, but we're still doing quite a lot over video and phone, which has a big impact. The fact that most of our services will continue to be offered where they are today means the transport impact isn't as great as you might at first imagine, but there is an impact on transport. And part of the work we've been doing with the councils is around carbon efficient public transport solutions by 2032, and whether there can be, more improvement in that. So it's a huge area. We could probably do a whole briefing paper on the carbon side of this, if that would be helpful.
I'm guessing you would prefer not to have that conversation starting now. Just so for colleagues on the tables, I have got Councillor Morris on the list and then Councillor Brophy. So I think we're after that, unless anyone waves their arms at me and says that's not fair, Steve, I think we'll move into debate because I'm very conscious of time. It's 9:30 and I'm sure we really would like to be out by 10. You really want to get that one in? Can you put Councillor Williams and then we will draw the line. Okay, thank you. Councillor Morris. Oh, where? Brophy? That was you.
As I understand, there's currently a maintenance backlog at the hospital of about £40 million. And I understand there might be the temptation that if you are moving out of the building, or some departments are due to be closing in a couple of years' time, that you might decide to leave the maintenance and let it go. So can I have an assurance that the building will be safe and fully maintained until it is no longer used, until sections of it are no longer operational?
So it's an easy answer at the Royal Hampshire, because the Royal Hampshire we are investing in and keeping. So actually we need that building to be in good condition, and some of this money will be used to tackle that backlog maintenance. It's more difficult at the Basingstoke site because the main tower block there will, whether we rebuild on that site or somewhere else, we'll be knocking down that tower block. So making those decisions about, do you keep fixing the roof and how long do you keep doing that for, we will have to make those decisions in real time and decide whether that's money well spent or not. But at the Royal Hampshire, that's absolutely part of our real estate for the decades to come. So we do need to keep on top of all the maintenance there. Yeah.
Councillor Williams. Sorry, we missed you on the list. Okay, Councillor Brophy then.
Thank you. Actually, it just follows up quite neatly to Councillor Morris's question on safety, but not safety of the infrastructure, but on services. In many ways, your consultation document's done a bang-up job on persuading us and scaring us that these changes are necessary. You've mentioned the South East Coast Clinical Senate having significant concerns about safety in the A&E, and the Ockenden report concerns about maternity services as well, the fact that we are at currently minimum safety levels in Winchester. So I guess the question is, in the interim, are we safe?
Yes. I mean, you can never be, can never rest on your laurels in something that is inherently difficult to manage as acute healthcare or any healthcare, but we're very confident that we have the processes in place to ensure that we've got adequate staffing, that we have the ability to pick up when before and if incidents do occur, and the ability to respond to those incidents. So we're very confident. We work very carefully with our external areas like the CQC to ensure that we are currently providing a safe service. It is a challenge, and I think that is why what we were trying to get across in the pre-consultation business case is that there are some services in which we're having to employ more doctors and nurses, for example, than we would if we were able to centralise some of those services on a single site. So absolutely, workforce in particular is a challenge to allow us to continue to providing that safe care, but we are determined to continue to doing that. We have continuous improvement all the time, looking at when incidents have happened and looking at how we can continue to improve the quality of care all the way through. And that doesn't start in 2032. It's absolutely a very active programme now.
Councillor Williams, one last one, and then if you could keep that short and in one question, please.
I'll try my best. No, it's just on the topic of the final topic that we were covering in regards to the consultation itself. I just wanted to touch on the staff aspect of the consultation. So just reading through the documents, there were 200 staff that are gauged through listening events. I was just going to see what more can you be doing, or what more are you going to do to ensure that the staff are listened to. I have contacted, I used to work in A&E in Winchester, so I have contacted foreign employees, and they say they can't get away from the shop floor to go to any of these events. So what are you going to do to ensure that more staff are aware of what's going on, because it's their future, as you know, as well as ours.
Yeah, excellent. Well, thank you for working at the A&E there. So actually, even just today, I had an email from our communications team to the matron in the Winchester ED saying, thank you for the conversation. Sounds like shift change is the perfect time for us to be stood as people are arriving at work, people coming home from work. So we're going to be there at 7 a.m. on Friday morning, and we're going to do another evening next week, and we're going to try and work out so our folk who are organising all the consultation events are trying to talk to each team specifically and go, what might work for you? And one of the suggestions at Winchester ED was, if you could be there at shift change, you won't be able to have a 2-hour conversation because people will be desperate to go home or whatever, but you can give them information, you can answer any immediate questions. We're also trying to go out to team meetings. I was in the restaurant up at Basingstoke a couple of weeks ago, and I'm in the restaurant in Winchester, I think, in a couple of weeks' time, just over lunch times with flyers and leaflets and staff saying, please read this if you get a chance, but if you've got any questions, what matters to you, what do you want us to hear? So yeah, we're trying to be very bespoke to whatever works for different teams. Yeah.
Thank you, Councillor Becker. Is it going to be quick then?
It's very quick. So one of the hats I wear here is Cabinet Member for Communities and Engagement, and engagement is a very big part of that. In every consultation, we're really trying to make sure that we reach every pocket of our residents. The events that you've been holding have been great. You've been doing them online, you've been doing them at different times of day, and in person. But how do you make sure that you are reaching every group of people who may be affected by the change? I can see the change manager is being lined up to answer that, because it does seem that there are some communities who are affected more than others. Councillor Wise lives in Stanmore, represents Stanmore, and Stanmore is one of the communities that is referred to in your consultation document, but that is a population that is probably affected more than many others. So how do you make sure that people from Stanmore, for example, or Winnell, where I represent, have the opportunity to have their say? And if they're not having their say in the events that you're holding, what are you going to do to make sure that they can have their say?
Yeah, thank you. Really good question, because it is really important to us that we get that wide range of views, and that we're not listening to people who are able to attend the sessions that we've put on. We know that some of that is challenging. So there's a couple of things to that. One is we have got, as I said, a third party research organisation who works with us to deliver an element of this consultation. So there's all of the stuff that we're doing, which I set up on there, but they're also doing some targeted involvement and engagement. So they are looking at some of those areas that are identified where we know we've got particular populations with particular needs, or where we've done the analysis. And as you say, there are populations that are particularly affected, and doing phone interviews, so one-to-one discussions, small groups, a whole range of sort of research-led events to also make sure that we incorporate their views into this process. The other element is that part way through, we will do a bit of a check in terms of looking at who we've heard from so far. So that organisation will give us a bit of an overview of where the views are coming from, demographics, age, not at that point themes, but the actual overview and demographic information of who we've heard from, so that gives us enough time, you know, as we then approach the second half of the consultation, to really do some focus work if we identify that there are groups that we haven't heard from sufficiently, or where we want to make sure we're absolutely reaching those communities. So we do have a kind of a check and challenge in there, as well as some of those other ways of reaching.
Brilliant. And if you need help from any of the board councillors, I think we're all in touch with our community, so let us know if we can.
Thank you very much. Now it's 9:45. I'm probably going to get my wrist slapped by the chief exec for the time that we've taken. In council meetings, it's customary to have a debate where members can reflect on the meeting and share their views back to you in terms of what they've heard and what mattered to them. So I'm going to open up this session to debate. So put your hands up. Councillor Bolton, you seem to be looking at me quizzically as if I've missed you off a list.
It's an unfortunate problem that I have, but are you drawing the line on the questions now?
Is my intention. Okay. Is there a problem with that?
Just one question. So, yes. So the quick question was, one thing that did surprise me in the document was that you had no cause to project a greater need for beds in the 2030s than today. And that surprised me hugely, with advancing technology, robotics, to you name it, the ability to treat all sorts of diseases is going to go exponential, we hope. And is that really taking into consideration advances in technology and science? And do you really think it won't increase?
Yeah, so this has been hotly debated as part of the National Hospital Programme. I mean, actually, advances in technology usually mean a shorter length of stay, so you need fewer beds. I think the other thing you'll all be familiar with is there are people in our hospitals who would be better cared for at home. They are waiting for their onward care. We were told, and the basis of the business case is to model on the 1920 baseline. And what we recognise is that actually we have to factor in the population growth. We have to factor in the changes, as you say, to technology and changes in the way we do things. So we've talked a lot about same-day emergency care. Those people, when I was a junior doctor, they would have all been, they're seen and discharged in the same day. How many years ago they would have been in for 2 weeks. So the medical models are changing significantly. So we're trying to anticipate that. But what I would say is, so we've followed the instructions and that's our model. We're absolutely not cutting beds. That's really important. So all of the advantages of technology, we believe the increase in population, older population, sort of mitigates that. So we need the same number of beds. But the new hospital programme are really aware that there are concerns about this. So there is some national demand and capacity work going on. So we may well refine the number of beds that is required as we go through the next more in-depth stages of the planning. So, you know, it's a really live conversation about how you anticipate what you need in the future. And the worst thing for us would be to design the Winchester and the new hospital and not have enough beds. That would be awful.
Thank you. Yeah, my fear was that by remaining static, it was effectively a decrease in the number of beds because of the rising population and everything. Thank you very much.
Thank you, Councillor Bolton. That was a worthwhile question to have in, but I don't want to patronise you. Completely. I really would like to move to debate so that we can give the feedback to the team. So I'm going to open up the list. I think Councillor Bolton's already put his hand up. Was that just an acknowledgement of something? So I've got Councillor Bolton, Councillor Wise, Councillor Brophy, I'm sure, and Councillor Williams. So we've got a stretch of 4 here, and Councillor Morris. So I'll start with Councillor Bolton. Thank you.
Thank you. So I represent a district ward, Upper Meon Valley. I'm a Conservative, and the population that I represent are, I would say, more interested in speed of access and quality of service than it being necessarily in the same old building that it's always been in, from, you know, the conversations I have with people. And so I do get some reassurance from the things that you've said today. So it being at M3 Junction 7 versus Winchester, you know, from where I live, you know, if you're in an ambulance, you probably get there at the same sort of rate ultimately. And I think that, you know, I very much, in the parish meetings that I go to, and I've got some between, it varies slightly each month, but between 9 and 12 parish meetings. So I cover a lot of people, or not a lot of people, but a big area, if you see what I mean. And so I very much promoted that they go online, get the real facts. Don't believe what you have pushed through your door on leaflets. Don't believe what people say, but go to Hampshire Together and get the real facts about the decision that's being made and understand the issues. I appreciate this is an enormously complex problem. It's verging on the intractable, and you're not going to please all the people all the time. I think that, you know, it will be an exercise in having the least number of people upset by the decision that you ultimately make. I'm reassured and happy that you've clarified that you are not being politically influenced, because I think that's outrageous if it's true. And so I'm pleased that that's not happening. Good luck with it. And I hope that, you know, the money comes as I'm sure it will. And I realise that this is taking an enormous amount of your time and effort, and I thank you for it. Good luck.
Thank you, Councillor Bolton. We're going to move on to Councillor Wise.
Yeah, I think I can't share Councillor Bolton's optimism that this money will come. I think we've got a Conservative government that seems to enjoy cutting large infrastructure projects and sending that money off anywhere. You know, just look at HS2. That money goes off to build roads in London. Unbelievable. I can't imagine us seeing this money when it's so far in the future as well. I don't know, especially in an election year, it just doesn't. It stretches what I can believe. I think that yeah, a government so willing to make cuts is gonna give us this money. I wish it would, but I just personally I just can't see it happening.
Thank you, Councillor Wise. Councillor Brophy.
Thank you, Chair. I'm actually incredibly encouraged by everything I've heard here. I am completely convinced by the case for the new model. I can see why you're excited. I can see why it's compelling. But I can also see why we need to talk about saving the A&E. And I think the perception of saving a service is very important to bring back. It is inherently political. That's why we do politics. So let's not apologise for that. For many of us, this issue is just one of geography. And I think we're in Winchester trying to be persuaded that while you're in your organisations, Hampshire is your your catchment, your area of responsibility. For us, the area that we have is far more local. For some of our most deprived communities in Winchester, it is hyper local. It's not about whether you can get to Basingstoke. Sometimes it's, can I even get into the town centre? And in that context, I think there's some serious issues about social inclusion around travel and the cost of travel. I mean, we can all talk about the time it takes to get there on a blue light service. We can talk about the time it takes to drive at motorway speeds in our cars that we all presumably may have. But the question is, if you're getting there in a taxi, if you're getting there, or even in your own car, fuel costs, getting there further costs more. This is an inherently more expensive prospect for many of the people looking at it, and they want their access to be saved. So whether you treat it as saving an A&E or saving a particular service or saving a particular building, I think what's behind a lot of the concerns, a lot of the campaigning, a lot of the politics is how you can save that access and keeping that I suppose the question of social inclusion alive and on the table for all this, because that's part of your to-do list and your KPIs presumably, but it's not the whole of it, and presumably there's also a balance sheet involved, and so we just need to make sure residents aren't lost in that. Thank you.
Councillor Williams.
Sure. Firstly, apologies for the sort of intense questions that you've had. A lot of them from residents, but our job is to try and scrutinise as much as possible and get those answers for our residents. I mentioned, obviously, I had a 9-year career working in A&E and I absolutely enjoyed it. So I do have a personal connection to wanting to keep that A&E service, but that personal connection does extend to a lot of residents' concerns from where I represent Bishop's Waltham and the already stretched QA Hospital, Southampton General, who combined have had 3 critical instances since your consultation has gone live. So I have real concerns about those. The new elective hub that's happening, regardless of any of these proposals, is fantastic and will alleviate a lot of the elective surgery from QA Southampton. So I'm quite encouraged about that. I am very encouraged about getting those specialist services all in one place, but I do think the loss of A&E, paediatrics, maternity at Winchester, with A&E in particular, and that sort of life-threatening emergency being in a locality that you're close to, it's really essential in keeping. I'm really disappointed that it's not one of the options that we could comment on or scrutinise further, or further see the reasons why keeping A&E wasn't an option put forward in the consultation. And then finally, and it is out of your control, I'm very concerned about the money. There is a political process in regards to that. The National Audit Office, the Public Accounts Committee, to which my MP Flick Drummond is a member of, have all thrown doubts over the amount of money that's going to go towards the hospitals, especially with this hospital being in a cohort 4, and the RAC hospitals being prioritised first. So I'm very concerned that you put forward the proposals, even if the proposal was for keeping an A&E and having a new hospital with all these specialised services centralised, whether the money would ever show up for that new hospital and the regeneration of Winchester. So I have real concerns about that, and I fear that going down this road, it'll come to a point where the money has run out for new hospitals. Winchester, the new hospital proposed at Basingstoke, will be at the bottom of that list. So I have real concerns that you're putting in all this effort and the money will never be there. I'm sure you've had those concerns, and I'm worried about them yourselves. I'm also concerned about staff and travel as well. So it does encourage me that you have been looking into these aspects. A lot of them are dependent on other services like Hampshire's transport plan coming later this year. But then I also have concerns about the social care budget and the increasing demands on social care in Hampshire, and the County Council's 132 million hole in their finances, and how they're going to be able to support social care moving forward. I mean, just in Bishop's Waltham, a care home is being proposed to be closed, unfortunately. So I know that's a lot to take in, and apologies for sort of throwing it all at you, but I just think they're really important considerations moving forward.
Thank you. Councillor Williams, your passion on the subject comes through. Councillor Morris, and then we've got Councillor Brooke.
Thank you for answering my questions about how intense they were put. I'd be very surprised if there's anyone here who has any objection to a new hospital being built in Basingstoke at Junction 7. I mean, let 1,000 blossoms bloom as far as new hospitals are concerned. I think the main opposition is going to be the downgrading, which is how people see it, of Winchester A&E, and particularly the maternity and stroke services, because it's very easy for people to draw a contrast between a situation where if there's difficulties in labour and someone is treated within minutes or seconds in the same building, and having to get into an ambulance for 20 minutes, 30 minutes to Basingstoke. And the same with stroke, where if you're in Hampshire, if you're in Winchester Hospital and you have a stroke, you'll be seen within minutes or seconds. And you're now looking at the situation where you're on a journey ahead of you and you may have a less favourable outcome. So those are two areas where I think people would like more reassurance. And I personally would like to see more of a plan in terms of how it will affect the ambulance service and how it will affect response times, because I thought that was a sort of glaring omission from the impact assessment. Thanks.
Thank you. Councillor Brooke.
Thank you, Chair. I just want to say thank you to all of you for answering our questions so robustly. I feel tonight you've been used as a bit of a political football in some ways. So for that, I apologise on behalf of the group. I think that some of the statements we've had this evening on how much more expensive travel is going to be, when Winchester is typically seen as one of the more wealthy areas, and actually the travel expenses will be far significantly less for people from Newbury, for example. I think it's a little narrow-minded. So I think actually it makes it more balanced and fair across the wider picture. And I also think for concerns over staff at something that's at least 8 years away, some of your staff won't even have started their NHS training yet. And they certainly have 8 years to plan what they might want to do. So I'm really glad that you're talking about this now. I would be, I'm hoping that you've already had some preliminary discussions about planning, because I would hate that to be the thing, knowing how difficult local authorities can be about planning, that scuppers you. And I absolutely think for those who are really concerned about the A&E, they haven't seen a really good urgent treatment centre. And the one closest to me is Petersfield, and that's excellent. So unless you've seen a real excellent urgent treatment centre in action, I think you talk from a place of concern rather than knowledge. So I thank you again for coming on this evening. I really hope this goes ahead. I really support it. So thank you.
Thank you. Firstly, Thank you very much to all of you for coming along this evening. It's somewhat later than maybe expectations were set. I'd also like to thank members of the public who have stayed with us to listen to the answers, and I hope that the combination of the questions has picked up most of your points. It's always pretty difficult when there's probably enough questions that we could have asked that we could have carried on for at least a second or third shift of the same amount of time. The objective for the meeting was for Health and Environment Policy Committee members to scrutinise the proposed new hospital consultation. And I think lots of questions have been fired in. I think there's been some fantastic responses. You've clearly done your homework. I hope the debate from the councillors helps. There's clearly slightly contrasting views, so I'm not going to attempt to sum it all up into a single statement. As I said right at the start, this meeting will just be one of the inputs that will inform a response which will be led by Councillor Becker on behalf of the City Council. I think just from my own perspective, you know, we've talked a lot about location, and I think that, you know, I understand the sort of logic of consolidation. I can see from a, you know, I'm not an expert obviously, but I can kind of follow the logic of consolidating your experts and specialist resources, and I can see how that might lead to efficiencies. I can see how maybe you need a different infrastructure. So you were talking about anaesthetics that might be done differently. So I can see, you know, lots of reasons why you might need to, you know, consolidate your locations. I think, as Councillor Brophy said, in relation to consolidation, it does end up moving the places that you need to get to. And it's not always when you're blue ambulance, it's when you're blue lighted, it's when you have to get there under your own steam that I think those issues start to come out. And I think there definitely is a distinct risk that certain, you know, pockets of our population, and despite what people, you know, Winchester is overall very, you know, generally well-off location, but we do have pockets of people who are not that fortunate. And it's those people that I think we're really trying to speak up for here and highlight that the lack of a transport strategy or the lack of a commitment to a transport strategy that those people can use is a bit of a concern. And it's very, very difficult for people to look at options and think, oh my God, how am I going to get to junction 7 of the M3? Yeah, it's difficult to just get around Winchester at times. So I think we do need to think about that. On the finance and funding and so on, I know all that stuff is way out of, you know, it's out of your hands, and I think I commend you for being in the game. You know, it's clear that Basingstoke needs a new hospital, and I believe Nick would probably say, well, actually Winchester does as well. But so it's good that you're in the game. I am concerned, you know, having listened to that parliamentary committee, that it's just not got the momentum, and I'm not sure I can see the funding really exists. And if we can get confirmation, that would be good. But that does concern me, and it more concerns me about what happens in the interim. You know, someone said to me there are going to be 16,000 babies born between now and the date that that you're talking about a new hospital. You know, the community here needs excellent maternity services accessible to them here and now. So that does concern me, is that, you know, it could drag on to, we could be partway through it and then it gets extended. And then that time for when we get those excellent services gets pushed out further. I thank you for the comments on the green, the carbon usage. I think I'll take it at this point as read. I know those calculations tend to be extremely complicated. We talked a little bit about consultation process and involving those people who are a little bit, not able to get to consultations. Certainly when I look round the two in-person sessions that I've been to, I didn't feel like there was a rich diversity of the population there. I hope you're picking them up in different forums. Overall, I think I hope you feel like it's been a worthwhile exercise, and I apologise for the time of day. I'm sure you're looking forward to dinner, seeing the kids if they're still up, and getting on with your lives. And I no doubt may see you at a further one of your consultation meetings. So with that, I'm going to close this meeting and thank everyone for attending. Thank you very much.